per person. And without further ado, we shall invite Dr. Jigish Ruparelia to speak to us on his findings on guidelines for management of acute subdural hemorrhage and traumatic contusions. Is it an exercise in futility? Please.
Good morning, everyone. So, suppose I were to tell you there are some guidelines for the audience present in this hall. And if we look at these guidelines, what do? They bring some discipline, they bring uniformity, they add a sense of decorum. And this is how guidelines are helpful. They ensure uniformity, they ensure safe practice, they standardize care across all centers and all patient populations, thus providing a consistency of care. They ease communication and follow up in case of referrals, and they build a parity of knowledge amongst the staff. But suppose I were to tell you there are also some guidelines for guests staying in this hotel. And if you look at these guidelines, they seem inappropriate, they seem excessive. And this is how guidelines, when applied inappropriately, can also be a drawback. Because they limit individual clinical judgment, they de-skill professionals by reducing their capacity to think for themselves, they limit the quality of care, they lack local relevance, and there's also a risk of providing inappropriate treatment. And this is because one size does not fit all. Good morning, I'm Dr. Jigish, representing the Department of Neurosurgery at AIIMS Jodhpur, and I'll be talking about the role of guidelines in the management of acute SDH and traumatic contusions. The effective management of traumatic brain injury is a challenge for all neurosurgeons, and this is because there's an immense heterogeneity in clinical presentation and radiological findings. We all know about the standard guidelines for EDH and we all follow them. But the management of acute SDH and traumatic contusions is more subjective. So these guidelines that we talk about, the Brain Trauma Foundation guidelines, let's have a look at them. Specifically, the guidelines for the surgical management of brain injury. What do the guidelines state for EDH? We all know them. The guidelines state that any EDH more than 30 centimeter cube volume, 15 mm thickness, or a 5 mm midline shift should be operated. And this is because EDH is an extra-axial, extradural injury. And an EDH in the frontal, parietal, temporal region will behave in the same way. But let's come to acute SDH. What do they say? The guidelines talk about the thickness of the SDH, midline shift, GCS, pupils, and ICP, 5 parameters. For contusions, they talk about progressive deterioration, ICP, signs of mass effect on the CT, and the volume of the contusion. For posterior fossa lesions, the guidelines are a little more vague. They say any patient with neurological deterioration or dysfunction should be operated. The problem with these guidelines is they are based on retrospective studies of small groups of selected patients. And it has been shown that although decompressive craniectomy deals with ICP and edema, but it does not necessarily improve outcome. The rationale for ICP monitoring has also been challenged. And overall, there is no clear consensus on indications, extent, and timing of surgery. And this is because there's a lack of high-powered randomized trials due to pragmatic, ethical, and methodological barriers. The best trial that I talked about by Randall Chestnut, published in 2011, showed that both groups, the ones which were monitored by ICP and the ones which are not monitored, had an overall similar survival. However, overall throughout the world, there is still a lot of emphasis on following these guidelines. If you look at this paper from US, they say that adherence to evidence-based guidelines has improved over the years, and being in a level 1 or level 2 trauma center and having standard protocols is associated with good adherence. The problem is they also say that this probably suggests that patients who are managed in these centers have improved outcomes, but there is no evidence for that. So what did we do? We did a small departmental survey, which included the faculty in our department and the independently practicing alumni. And we asked them if they are aware about these guidelines. So most of them are aware. And all of them, the guidelines that they are aware about, they follow, are the Brain Trauma Foundation guidelines. When you ask them how frequently do they follow these guidelines for SDH and confusions, about 50% said sometimes, rarely, or never. 25% said often, and 25% who said always probably lied. But when we asked them what is a better approach, most people said an individualized approach towards each patient, depending on the radiology and clinical status, is a better way of managing these patients, or using one's experience to cleverly balance guidelines with an individualized approach. And this is because when we ask them what are the factors that they consider in making operative decisions, so yes, the size of the SDH matters, the mass effect matters, the GCS matters, which is all included in the guidelines, but also the duration since injury, the age of the patient, the focal neurological deficits, the other associated injuries, and the location of the lesion, that is the lobe involved. And this is because there's a lot of lacunae in the guidelines that we have currently. And this was, although a local study, we also reviewed literature. So this is a study from Europe which says that there is a wide variation in adherence to guidelines, even within a center. And the factors that surgeons consider include high ICP, pupils, guidelines, age of the patient, but also expertise of the surgeon, opinions from other disciplines, time from trauma to ED, and if the TBA was a result of a suicide attempt. And the adherence to guidelines is the least for confusions. There's another paper from the US which says that guideline adherence will probably be improved if these are based on stronger evidence. Another paper which says that the lowest adherence was when making surgical decisions, only 14%. And this is why even the authors who actually made the BTF guidelines had to come out and say that these guidelines do not always fit to all resources and all circumstances. So what is the solution? The solution is probably that the guidelines, when making operative decisions, should leave a lot of it on surgeon judgment, especially pre-op and intra-op. So I'll conclude. The multiple patient-related clinical and radiological factors that affect patient outcome. SDH is an intradural injury. Contusions are interaxial injuries, which is why an SDH in the frontal region will behave differently than a temporal pole SDH, and a frontal lobe contusion will behave differently than a temporal contusion. And there is no clarity about coop, contra-coop injuries, multiple contusions, and multiple types of injuries. And we have examples that show all of this. So focus should instead be on exposure to more and more cases, especially during training period, and supplement actual exposure with virtual cases and simulations. Thank you.
Thank you, Dr. Jigish, for a thought-provoking presentation.
Now I invite the next speaker, Dr. Akshay, who will be presenting his work on outcome prediction and survival after decompressive craniectomy for elderly traumatic brain injury, impact of frailty.
Good morning, everyone. I'm presenting on predicting outcomes after DC in the elderly on the role of frailty. TBI is among the top 20 causes of increased DALI in the world. The population of most countries, including India, is aging. Elderly TBI is on the rise. Decompressive craniectomy is a life-saving procedure. It's a last resort procedure. It has been studied multiple times, showing slightly better mortality but ambiguous functional outcome. Frailty is a new concept, relatively new concept, which is a cumulative impact of the reduced physiological reserve and increased comorbidities. Is it a better predictor as compared to chronological age in the elderly? It has been shown to be a better predictor in multiple surgical interventions in the elderly, especially neurosurgical ones. For example, lumbar degenerative disease, glioblastoma, etc. Few previous studies have evaluated frailty in the context of elderly TBI, but no holistic evaluation has been done for decompressive craniectomy. So our research question is frailty as a metric of biological age a better predictor of in-hospital outcomes, long-term functional outcomes, survival, and caregiver perceptions compared to chronological age after DC for elderly TBI? And can a composite model incorporating frailty be created for predicting these outcomes? This is a retrospective cohort study. 200 patients above the age of 60 underwent decompressive craniectomy in our center from 2009 to 2023. Telephonic contact would be established with 140 of them. They underwent an NCCT head at presentation, standard ICP reducing measures. Both a bilateral as well as a unilateral decompression was included, and both primary and secondary decompressions were included. These were our data points. More importantly, frailty was defined using the modified frailty index 5, which awards a single point to each comorbidity. Presence of even a single comorbidity is termed as moderate frailty, two or more is severe frailty. The data was collected by two blinded workers. Disagreements were mutually resolved. Telephonic interview was conducted by a third blinded worker, and the data was analyzed by a fourth blinded worker. Functional outcomes in dead patients are not included, so ghost cannot be one. These variables, that is the demographic data, the severity of the injury, Rotterdam score, ISS, frailty, in hospital variables, were our predictors. These were our outcome measures, that is the in hospital stay, the hospital outcome, mortality, functional outcomes, and long-term functional outcomes at 6 and 12 months, and the survival. The predictors were divided into an early group, the data for which is available at presentation, and an extended group, the data for which becomes available during the hospital stay of the patient. A univariate analysis was done. Significant predictors were used to construct the multivariate models, which were analyzed using the ROC curves. Survival analysis was done using Cox proportional hazard, and a subjective questionnaire was used for the perceptions. These were the subjective questions. We'll touch upon them in the discussion. So our cohort has a mean age of 65.97 years. 66% of them had severe TBI. 44% of them were severely frail. 63% underwent a tracheostomy during hospital stay, and almost half had culture positive infections. The mortality was 44%. Good outcome at discharge was 18%. At 6 months was 37%, and at 12 months was 63%. This is among the patients who were alive at this point of time. So mean survival was 40.64 years. So on univariate analysis, mortality was significantly predicted by age, injury severity score, the severity of TBI, and the Rotterdam score. All of these are early predictors. The functional outcome at discharge was predicted by the frailty and the severity of the patient, which are early predictors, and also if the patient underwent a tracheostomy, which was an extended predictor. Functional outcome at 6 months, similarly by frailty, severity, tracheostomy, and occurrence of hospital-acquired infections, two early and two extended predictors. At 12 months, again by these same four variables, frailty, severity, tracheostomy, and infections, two early and two extended predictors. On multivariate analysis, this was the ROC curve of mortality, which was predicted only by the early predictors, and the early as well as extended models for the functional outcome at discharge. This was the multivariate analysis for outcome at 6 months and 12 months respectively. The early predictors also had an area under curve of more than 80%. Only frailty and tracheostomy could independently predict survival, with increasing frailty and occurrence of tracheostomy having decreased survival. Excuse me, the slides are not moving. Yeah. So this was the distribution of answers across the subjective questionnaire. Among this, significantly, those with increased severity of TBI consistently required in-hospital care during the last month of stay. Those with increasing age and severity required continued neurosurgical care post-discharge in the last month. We'll come to the significant impact of frailty on perceptions in the discussion. So the clinico-radiological severity of TBI, the severity of other injuries, and chronological age predicted mortality. Frailty, the severity of TBI and tracheostomy predict functional outcomes at discharge. Frailty, the severity of TBI, tracheostomy, and occurrence of infections predicted functional outcomes at 6 and 12 months, that is long-term functional outcomes. So frailty is a better predictor of functional outcomes compared to age, but not of mortality. Tracheostomy is a significant independent predictor rather than a consequence of poor functional outcome, because multicollinearity was absent in multivariate analysis. The early predictors incorporating the early variables have a reasonable predictive power, but the extended models performed better, and healthcare associated infections did not impact short-term outcomes as much, but they impacted long-term outcomes, showing they have a underlying neurocognitive effect. Only frailty and tracheostomy could predict survival. A previous study had investigated frailty in the context of surgery for traumatic brain injury, but only short-term outcomes were seen, and frailty was a significant predictor in them as compared to age. Thus, mortality is determined by the severity of immediate trauma and chronological age, whereas functional outcome is determined by the biological age, the lingering effect of trauma, and hospital stay complications. Survival is only determined by biological age and tracheostomy, not by the chronological age. And the caregivers of frail patients experience significantly higher dissatisfaction with outcomes, psychosocial support, their ability to provide care. They have increased financial burden and frequently require extra familial help for the care of their patients. Thus, frailty is a better predictor of functional outcomes, survival, and caregivers' perceptions compared to age. If we use it as a factor for decision making in decompressive craniectomy for elderly TBI, it might result in better prognostication and resource utilization. Thank you.
Thank you, Dr. Akshay. We shall proceed with Dr. Hiroshi Karibe. He shall be enlightening us on the usefulness and limitation of the Japan guideline for the management of traumatic brain injury. Dr. Hiroshi?
And gentlemen, it is my great honor and pleasure to have an opportunity to speak at this conference. Today I present a usefulness and limitation of the Japan TBI guideline. The authors report no conflict of interest for this study. In Japan, traffic injury in younger generations occupied the largest part of severe TBI in 1990. This bar graph shows the distribution of severe TBI by age in the era. The x-axis is the age of patient, and the y-axis is the incidence of severe TBI. The traffic injury in younger generation occupied the largest part of severe TBI in 1990s Japan. Therefore, the severe TBI, especially due to traffic accident in younger generation, seem to be targeted for Japan TBI guideline. Japan TBI guideline has been proceeded since the late 1990s. The latest version of its fourth edition consists of A5 format 240 pages. It is customized to adapt Japanese medical and insurance system, social consensus, medical resources, and so on. As references, approximately 700 references are cited, including latest 243 out of 13,000 English and Japanese search references. As background, it has been reported that the adherence to the guideline is related to reduced mortality. The purpose of this study is to investigate the usefulness and limitations of Japan TBI guideline by analyzing the data from the Japan Neurotrauma Data Bank before and after guideline publication. Using JNTDB, patients with severe TBI suffered from traffic accidents were selected for analysis. Age, gender, patient situation in traffic accident, GCS score on admission, and the GOS score at the time of discharge were compared between before and after Japan TBI guideline establishment. As a statistical analysis, chi-square or man-Whitney U-test was utilized, and statistical differences were considered at significant at p less than 0.5. JNTGB is 2 years of TBI patient registration project with the participation of 32 facilities being conducted intermittently. Inclusion criteria is as follows. Results. This is a summary table of the background of patients with traffic injury. As this table shows, age, gender, patients' situation in traffic accidents are not statistically different between groups. The severity expressed by GCS score on admission is not statistically different between groups too. This component bar chart shows GOS in all cases suffered from traffic accident. The bar on top is Project 1998 before guideline, and the bar at bottom is Project 2015 at the latest. As this bar chart shows, the mortality was significantly lower in Project 2015 than Project 1998. But favorable outcome, shown as GR plus MD, was not significantly different between them. Focusing on patients with traffic injury in younger generation, which seemed to be a main target for initial guideline. As this table shows, age, gender, patient situation in traffic accidents are not statistically different between groups. GCS score on admission is not statistically different between groups either. This component bar chart shows GOS in younger generation suffered from traffic accident. Regarding the outcome in cases with traffic accident in younger generation, not only mortality, but also favorable outcomes significantly improved. Discussion. In general, it has been reported that the adherence to guidelines may reduce mortality. Regarding TBI, it has been reported that the adherence to Brain Trauma Foundation guidelines seems to be associated with lower mortality. In Japan, it has been reported that the adherence to Japan TBI guideline is significantly associated with lower mortality. It has been also reported that the preventable trauma death seems to be decreased. Therefore, the present results suggest that Japan TBI guideline is useful to reduce mortality in patients with severe TBI, especially in younger generations with TBI suffered from traffic accident. It is suggested that the Japan TBI guideline is quite useful to improve not only mortality but also functional outcome. Actually, the compliance to Japan TBI guideline has been increasing from 18 to 72% in major facilities which has neurosurgery department, parallel to the improvement of the outcome. In addition to the usefulness of the guideline, limitation has been also suggested in this study. This component bar chart shows GOS in older generations suffered from traffic accident. The mortality was significantly lower in Project 2015 than Project 1998, but a favorable outcome was not significantly different between them. In conclusion, the present results suggest that guideline is useful for clinical practice to improve outcome, especially in traffic injury in younger generation, to the main target for the guideline to be solved. A limitation of current guideline is also suggested, as only mortality but not functional outcome was improved in elderly patients, which should be solved in future. Thank you for your attention.
Thank you, Dr. Karibe.
Thank you.
And now we invite our next speaker, Dr. Ravi Teja M. He'll be giving his talk on odontoid fractures, a review of treatment of odontoid fractures at our center, current concepts, and overall treatment recommendations.
Good morning, everyone. Today I'll be talking about review of treatment of odontoid fractures performed at treated in our hospital, the current guidelines and the treatment perspectives. Going into objectives, it is to determine the outcomes of odontoid fractures treated at our institute. This is a retrospective descriptive study conducted between August 2022 and December 2023. Treatment call of both non-operative and operative was taken based on the type of odontoid fractures and all the pros and cons involved. Patients were followed up clinically and also with cervical x-rays. Patients with history of trauma and odontoid fractures treated conservatively and also surgically were included in this study. And patients who have had polytrauma, pathological odontoid fractures such as osteoporotic infections and neoplastics were, and also old and malunited and non-united fractures were excluded in this study. Results: 4 patients were included, in which 2 of them were medically managed and both were of type 1, and 2 patients who were surgically managed were of type 2. Going into discussion, these are the most common fractures of the axis and also the most common fractures of cervical spine in patients above 65 years age. Poor bone health and medical comorbidities contribute to increased surgical risk in this population. In non-operative management is associated with risk of non-union or fibrous malunion. Going into classification, the classical Anderson and Alonso classified these into 3 types: type 1, 2, and 3, as everybody knows. And there was a modification by Gror et al., where it was the type 2 and type 2 fractures were classified into type 2A, B, and C, where type 2 is a linear fracture, type 2A is a linear fracture, type 2B is anterior superior to posterior inferior, whereas type 2C is posterior superior to anterior inferior. And type C is classified if the superior part of the facet is also involved. Everybody knows clinical features, and they typically represent with neck pain after a fall, dysphagia if there is any large retroperitoneal retropharyngeal hematoma is present, and neurological injury will be seen in only 7.5 to 13% of the patients. Imaging, anterior posterior, lateral, and open mouth plain radiograph views are performed. CT and also MRI should be performed. Non-operative management can result in solid fusion, unstable non-union, or fibrous non-union. Fusion is governed by pattern of injury, whether it is a high velocity or low velocity type, fracture subtype, as I discussed earlier, associated ligamentous complex integrity, the slope of the fracture line, angulation. If it is more than 11 degrees, the chances of fibrous malunion and non-union are more, and displacement of more than 5 mm. Chances of non-union and malunion are more. Blood supply, bone quality, age of the patient, and also age of the fracture decides the outcome. Classically, type 1 and type 3 fractures can be managed in collar in most of the cases where posterior ligamental complex is integrity is maintained. Type 2 fractures should be considered for surgical management. Type 2A and B with intact ligamentous complex can be managed by anterior odontoid screw fixation, whereas type 2A and B without anterior intact ligamental complex along with type 2C should be managed with posterior C1 C2 fusion. Going into medical management, the first one is skeletal immobilization. Immobilization for a total period of 3 to 4 months, we can achieve fusion. Success rate depends varied widely in different in the literature. In frail elderly, if skeletal immobilization is considered as a treatment, fibrous non-union can be accepted as an acceptable outcome. Going into medical management, the first one is hollow vest arthrosis. It is definitely superior when compared to other cervical collars, but the thing is there are compared to other cervical collars, there are much more complications associated with it. And Johnson et al. Showed that the hollow vest allowed approximately 5 degrees less flexion extension at C2 compared to that of Philadelphia collar. It was 8.5 degrees in Philadelphia collar, whereas 3.4 degrees in hollow vest. The other medical management include Philadelphia collar, Aspen collar, Miami J, and cervicothoracic braces. Going into cases that were treated in our institute. The first case is 24-year-old male with alleged history of RTA and sustained injuries to neck. He presented with just neck pain and no neurological deficits. Uh, the picture showed the type 2A odontoid fracture with posterior ligamentous complex integrity intact. Uh, he was managed with anterior odontoid screw. The first two pictures show immediate post-op X-rays. 1 month followed up, and these second two pictures show the X-rays of the 1 month post-operatively. And at 6 months, we can clearly see there is a good fusion at the fracture line. Case 2, a 40-year-old female patient came to OPD with after 5 days of injury with alleged history after 2 weeks of injury with history of RTA. She had neurological deficits. She had left side shoulder, elbow, and wrist weakness. Bilateral DTS were exaggerated in both upper and lower limbs, and bilateral tone was also increased. It also showed type 2A fracture, and it was managed with anterior rodentite screw. This patient, immediate post-op CT was also done along with cervical X-rays, which showed a little displacement of a screw towards the left side. But patient 6 months post-op X-ray showed clear healing of the fracture line. Case 3, 21-year-old male patient with history of fall from height, about 10 feet, current pole. Clinical presentation was only with neck pain with no neurological deficits. It showed type 1 fracture. Patient was managed conservatively with Philadelphia collar, and he did well. 6 months X-ray showed clear healing of the odontoid fracture. Case for 24-year-old male came to EMD with history of self-fall from stairs and sustained neck injury. This patient was hailing from West Bengal and from poor social economic class. So I couldn't get his post-op. I couldn't get his 6-month X-ray. He also is doing well now. Complaints of occasional leg pain, but he's able to do his daily day-to-day activities and also doing well. Going into conclusion, medical or surgical management of appropriately chosen odontoid fractures have good clinical and radiological outcomes. Thank you.
Thank you, Dr. Ravi. Next, we'll have Dr. Ashutosh Kumar. He will be speaking to us on CT-based morphometric analysis of odontoid groove, a possible answer to the odontoid fracture classification enigma.
Everyone. Why do have so many classifications of odontoid fracture, and still we follow the earliest classification system that was given by Anderson and Alonso? So in next few minutes we'll be discussing why this kind of disparity is there. Good morning, everyone. I'm Dr. Ashutosh, and I'm assistant professor in Department of Neurosurgery, SGPGI, Lucknow. And in next few minutes, we'll be seeing what is the enigma that is associated with the classification of odontoid fractures, and what could be a possible solution to this enigma. So this is the timeline where we can see that 1974, first time Anderson also gave the classification of odontoid fracture, and today also we prefer to use this same classification with few little modifications. First time Anderson also gave a classification that was based upon the fracture location. Because of this, they told that the type 1 fracture is one that is from the tip of the odontoid. The real problem started from here only, because the terminology of tip of odontoid was not very well defined. Also, the work of Punjabi told that the attachment of apical ligaments over the tip may be variable, and sometimes the ligaments may extend whole through the posterior surface of the odontoid. So, and also they found that there is a gray zone from the point of attachment of the apical ligament to the attachment to the point where the transverse atlantal ligament goes behind the odontoid. There is a gap of 5 millimeters. So if a fracture happens in this 5 millimeter gap, we won't be able to classify it according to Anderson and Alonso. So This problem was solved partially by Brewer et al. What they did was, they did two things. First, they defined what is the line that will decide if it is a type 1 fracture or type 2 fracture by taking the line from the inferior border of anterior arch of C1. Secondly, they subclassified type 2 fractures. But we know that many times we find odontoid fractures which cannot be classified in any of these groups that was given by Brewer. There was another classification by Roy Camilli where they focused upon what kind of intervention that we can do. The type 2 by Roy Camilli classification was amicable for intervention by odontoid screw. While it did give some perspective in what kind of intervention we can do, but it failed in classifying the married type of fractures that we observe in odontoid fractures. Coarse classification. This classification was almost near to solving this enigma. They identified the importance of transverse atlantal ligament in deciding the stability of the odontoid fractures. So their basis was biomechanical. It was based upon anatomical landmarks. They used X-rays and transoral X-rays to decide these lines. However, there was a point that reduced the precision of this classification. The transverse atlantal ligament, it arises from the colliculus atlantis, that is at the lateral mass of C1. From there, it slacks by 21 degrees, go posterior to the odontoid. So the line that Coase used was a transverse line connecting the innermost part of the lateral masses, that is through the colliculus atlantis. So this line does not correspond to the actual axis of the transverse atlantal ligament. So there lies the lack of precision in this classification. So when we reviewed all this literature, we found that all these classification aimed at three important things. First, there has to be a biomechanical basis of classifying this odontoid fracture that we decide the intervention, is it to be done or not. Second, the anatomical landmarks that can be used very easily on the existing radiological investigations that we do, that is the CTs and X-rays. So the anterior stability of the odontoid was already defined by Brewer, that is the C1 anterior arch. But the rotatory movement of C2 within the C1 is possible because the anterior movement is prevented by the C1 anterior arch, but the posterior is prevented by the transverse atlantal ligament. So we used a marker that could suggest what is the location of transverse atlantal ligament. In trauma, most of the times we are doing CT scan. So we assessed if this odontoid groove, which is the impression of transverse atlantal ligament or the posterior surface of odontoid, to be a physical marker for the level of transverse atlantal ligament. As a pilot study, we observed first 4 patients and found that this odontoid groove was present in all of them. So we planned a study where the primary objective was to develop an anatomic biochemical classification with the secondary objectives of first assessing the feasibility of using this odontoid groove. Secondly was to correlate if the line given by Brewer actually correlates with the odontoid groove. If it does correlate, then there is no need for new classification. But if doesn't correlate, that means it cannot predict the posterior stability of odontoid fractures. And lastly was because this line, when we are doing a CT scan, the position of the head can be variable. So the line that you make from the lower border of C1 arch may not be the same when it is in flexion or extension. So there lies a fallacy. So we did a CT based morphometric analysis of this odontoid groove to assess its feasibility, and we analyzed few important markers, that is the odontoid groove, the line L1 which is from the lower border of C1 arch, and L2 which joins the lower border of anterior C1 arch and the posterior C1 arch. As a result, we found that up to 78% patient we were able to define this odontoid groove, which was statistically significant. Also, we found that there was no concordance between the level of transverse atlantal ligament and the lines L1 and L2, thus confirming that an independent analysis of odontoid groove is important for deciding the posterior stability of odontoid fractures. So based upon that, we proposed a classification system where we defined where is the fracture on the anterior surface of odontoid and where is the fracture on the posterior surface of odontoid. This gave us 5 different types which had a clinical implication, where Type 1 was above both C1 anterior arch and transverse atlantal ligament, which are theoretically biomechanically stable and does not require any intervention, while type 5 are actually involving the body or comminuted fracture of the odontoid, which need further investigation in the form of flexion extension CT, while type 2 and 3 are oblique fractures. So this is a proposed classification system where odontoid groove can be actually assessed and used to define the posterior stability. And secondly, there are certain limitations to this study, mostly because this is purely at present theoretical. What we need to do is we need to further corroborate it clinically with the actual fractures of the odontoid and see if it actually works. Thank you very much.
Thank you, Dr. Ashutosh. Next, we shall proceed on with Dr. Chirag Jain. He shall be speaking to us on a hinge craniotomy as an alternative to decompressive craniectomy for trauma.
Hi, good morning. I'm Dr. Chirag. I'm a senior resident at NIMHANS. So let's get into it. I think all of us know this patient, probably a middle-aged male or female with severe traumatic brain injury, GCS of maybe around 8, comes to our casualty and we operate on him and find that there's a brain bulge and we leave out the bone flap. Following which the patient survives, but usually comes back with some of the other complication. That could be hydrocephalus, subdural effusions, sunken skin flap syndrome. But there is something that we have forgotten is actually a complication of DC. Is that the patient has to undergo a second surgery known as a cranioplasty, and that itself is associated with its own complications like hematomas, seizures, wound infections, and all of these can happen in patients undergoing decompressive craniectomy. But Rescue SDH did tell us that it is possible that for patients who are undergoing surgery for acute subdural hematoma, we might choose to leave out the bone flap or leave it in, and it actually does not make any difference with outcomes. But I'm sure that most of us do not feel comfortable with the idea of leaving the bone flap in and developing brain bulge later on and then having to take it out afterwards. So is there a solution which is able to manage raised intracranial pressure but still avoid the problems of a decompressive craniectomy? So in 2007, 3 groups independently described a technique known as hinge craniotomy. And what is it exactly? Basically, it is an alternative to decompressive craniectomy in that it allows you to replace the bone flap, and the bone flap expands outwards. So that's why it's also known sometimes as an expansile craniotomy. And this allows you to accommodate brain bulge. So that has been done in multiple different ways by multiple different investigators. Some use plates and screws, some cut up the bone piece into multiple pieces and tie it up with threads, and some use these special fancy plates to help it lift up a little bit. The main thing is once the ICP settles, the bone flap should fall back into place and you do not require second surgery for cosmetic purposes. So we have previously studied this at NIMHANS before. This was a retrospective study, and this is a technique where we use. We cut up the bone flap into 3 different pieces, tie it up loosely with threads, and fix it to the rest of the cranium, again using threads. So this allows the bone flap pieces to expand outwards and accommodate brain bulge. So our study, the previous one that we published in 2021, was a retrospective study evaluating 31 hinge craniotomy and 36 decompressive craniectomy patients, and we found that outcomes were better in hinge craniotomy as compared to decompressive craniectomy as well. But can it really be an alternative to decompressive craniectomy? So there have been multiple studies which have evaluated this technique. 5 retrospective, 1 prospective, and one randomized clinical trial has been done. But so far, the study quality is not that great. But what we have found is that outcomes were better with hinge craniotomy, or at least similar, and it was associated with a lower complication rate. So what we did in our study is we designed a prospective study to evaluate outcomes following hinge craniotomy and decompressive craniectomy for patients undergoing surgery for traumatic brain injury. And our objective was to prove that it is a suitable alternative to decompressive craniectomy in patients who are undergoing surgery for mild and moderate brain bulge. So we did a prospective cohort study. The inclusion criteria was patients undergoing surgery for an acute subdural or for a contusion. And basically, if the patient had a severe brain bulge, we took out the bone flap and they were excluded from the study. If they had no brain bulge, if the brain was lax, we replaced the bone flap and again they were excluded from the study. But the patients who had a mild or moderate brain bulge, where you're just not sure as to what you want to do, do you want to take out the bone flap or do you want to place it back in? That is where we decided to divide them into a hinge craniotomy or decompressive craniectomy group, and these were both included in the study. So the adequacy of surgical decompression after surgery was evaluated with three criteria. One was radiologic, that was a reduction of midline shift and reduction in effacement of basal cisterns. Optic nerve sheet diameters for non-invasive ICP monitoring and invasive ICP monitoring by parenchymal ICP monitors. The primary outcome was to demonstrate this adequate surgical decompression, and the secondary outcomes were Glasgow Outcome Scale Extended Scores at follow-up and complications associated with the surgical procedure. So we were able to recruit 40 patients, 16 in the DC group and 24 in the HC group, and these are the results as follows. There were no significant differences between both groups in respect to demographic data, that is age, sex, and prior medical and behavioral history. Preoperative variables were more or less same. There were no significant differences with GCS, motor scores, pupillary asymmetries, and the way that they had developed the RTA. Preoperative lab variables, which are usually important when it comes to outcomes with traumatic brain injury, like hemoglobin and RBS, as well as the CT diagnoses, the amount of midline shift, the amount of basal system effacement, parenchymal lesions, and the cytopathology were not significantly different between both groups. Preoperative optic nerve sheet diameters were elevated in both groups. They were above 6 millimeters in both groups, and preoperative ICPs were elevated in both groups as well. They were both above 22 millimeters of mercury in both groups, but not significantly different in both groups. The time from injury to surgery in both groups was a little different, but not statistically significant. It was found that the duration of surgery in the DC group was 2.5 hours as compared to 3-hour duration in hinge craniotomy. And that is because it does take a little bit more time to cut the bone flap. But we have to remember that the patient undergoing a DC, if they survive, they are going to undergo a cranioplasty. So that time is easily offset. Intraoperative complications were similar between both groups. Post-operative midline shift was reduced in both groups. It was below 5 millimeters in both the groups and not significantly different. The reduction in midline shift was almost 5 millimeters in both groups. Post-operative basal cisterns had improved in most patients, and they were not significantly different in both the groups. And the size of craniotomy was at least 13 centimeters in both the groups. Post-operative optic nerve sheet diameters had also fallen in both groups, and post-operative ICPs were maintained below 20 millimeters of mercury in both the groups. The duration of hospital stay and the complications during hospital stay were also found to be similar. What is really important is that the Glasgow outcome score at follow-up in 9 patients in the DC group had died, and 8 patients in the hinge craniotomy group had died. Favorable outcomes are found in 13 out of 24 patients in the hinge craniotomy group and only in 7 out of 16 patients in the decompressive craniectomy group. So this is a patient who underwent hinge craniotomy. As we can see, the bone flap was able to lift up and accommodate brain bulge post-operatively. Cosmetic outcomes were analyzed for a few patients following hinge craniotomy and were found to be adequate and rated as satisfactory by the patients. So to summarize, the hinge craniotomy and decompressive cranectomy were comparable in achieving adequate surgical decompression as assessed by radiology, optic nerve sheet diameters, and post-op ICP monitoring. It did take longer by 30 minutes on an average, but we have to remember that this is easily offset by the second surgery you would have to do for patients undergoing a cranioplasty in DC patients. These were the results of patients undergoing decompressive cranectomy. 9 out of 16 patients are dead. There are 7 survivors. 3 have undergone a second procedure of cranioplasty, and 4 are still awaiting a cranioplasty, some of them for more than a year. The 2 patients did develop a surgical site infection, one cranial and one abdominal. In a hinge craniotomy group, on the other hand, 8 patients are dead, 16 survivors are there, 2 did develop a surgical site infection, and the rest of the patients in the group did not have to undergo a second surgery. So to conclude, hinge craniotomy was found to be a suitable alternative to decompressive craniectomy for surgical decompression in patients with acute subdural hematomas and contusions of mild and moderate brain bulge. The results are found to be equivalent or better and associated with fewer complications. Most importantly, we are able to avoid the requirement of a second surgery of cranioplasty. Next, we are planning to undergo a randomized control trial to evaluate the role of hinge craniotomy in such patients. Thank you so much.
Thank you, Dr. Chirag. There's one announcement to be made. There's a MCQ session in Hall A. All the residents and as well as the junior consultants can register for that. And I now open the session for questions from the floor, please. Can you give the mic to sir?
So with increased life expectancy, it is not unusual that you will be operating more and more elderly people. Like by 2050, 1/3 of Indians will be 65 years or above. So age will not be any more bar to do surgeries or aggressive treatment.
Yes.
So what you present like clinical frailty is an important consideration.
Yes, sir.
So we also did a study on geriatric traumatic brain injury, and we did not do frailty score, but we did medical comorbidities. So in that also, we did not find that increasing age was not associated with worse outcomes.
Yes, sir.
It was again same. What is there in young patients, GCS, pupils, nervous system, only those factors were significant predictors of outcome.
Yes.
But yes, we did not do frailty score. So actually, frailty score is used in resource limited settings on deciding about the aggression of the treatment, and for end of life support treatment, that also frailty scores are used. So I think it's a good study.
Thank you, sir.
Sorry, I joined late, Dr. Jain. So I wanted to know, did you measure the ICP as well? I didn't hear that. Okay, so what was the difference in the decompressive and so what was the ICP recorded in the hinge craniotomy group? I was interested. Intraoperative.
Intraoperatively, it was measured like immediately preoperatively.
Okay.
So in the immediate preoperative period, in the hinge craniotomy group, the average was 24. And in the decompressive craniotomy group, the average was 34. But the standard deviation is quite significant, so significantly does not make a difference. But intraoperatively found that in both the groups, it usually fell to around 4 or 5 millimeters of mercury.
So my one query was that in patients where you did hinge craniotomy, like the scan you showed, maybe was the kind of patient where I would not have proceeded with decompressive and might have just left the bone flap back.
Right. So the main objective is when you have that confusion, should you replace the bone flap or should you not replace the bone flap? It is usually for those patients.
So you're not putting it as an alternative to decompressive, you're putting it as an alternative where we have doubts.
Yes.
Decompressive versus...
Yes, but a lot of those patients would undergo decompressive craniectomy in a lot of scenarios.
No, okay, whatever. Yeah. So that's what. So I wanted to say that it's an alternative. It's an alternative where we have query whether we should proceed with decompressive.
Yes, the basic idea was mild and moderate brain bulge.
Thank you.
Tried of removal of temporal bone strip instead of doing hinge craniotomy. Just remove the temporal part of the bone and keep the parietal intake, like that.
That would take care of the compression that would arise at the level of the brain stem. But in a lot of these patients, the entire brain bulges, so it is difficult to just remove the temporal bone and leave the rest of the frontal and parietal bone intact and let it compress the rest of the brain. So we find that if we allow the entire bone flap to expand outwards, it does allow for a better decompression than just the temporal bone.
In both of your study, the comparison, you do duroplasty in all the cases?
Yes, for all cases, we do duroplasty.
In your Japanese data, I had seen that the maximum incidence of head injury death rate was at the age of 15. So at which age do you give the driving license? In India, I think it is at 18 years of age.
In that GNTB, we only studied the 15 years and older.
But
from from 2004, we have studied the age of between 60 and 15, but I do not analyze the data of the children.
But driving license, the
not driving race, just a usual traffic accident.
I see. Okay.
The most popular one is a traffic accident between pedestrian and car. The next was by motorcycle. The motorcycle traffic accident number is very decreased in Japan.
Thank you.
One question for you, like what is the rate of intracranial pressure monitoring from 1998 to 2015? Are you doing more monitoring now or less monitoring?
In Japan, the brain ICP monitoring is not so popular. So I think 30% of patients is monitored, but other 70% patients is not monitored.
Thank you, Dr. Hiroshi. I have a question for Dr. Ashutosh Kumar. What are the challenges which you actually anticipate towards the clinical application of this odontoid groove?
As such, we are using our database now for applying this classification to that database, and then once it is done, we'll be publishing it as a next study. As such, it is quite easier because in all of the patients, as a trauma protocol, whenever we are doing a CT head, we are doing CT cervical spine. Most of the times, it comes into screening. We do have a suspicion, yes, there may be odontoid fracture, but it does confirms only on the screening, where we are not doing any mobility studies. So a mobility study with this classification will be done only if it goes into type 5. Otherwise, we can actually completely avoid this mobility study in rest of them, because biomechanically we are proving that, of course, the other type 2, 3, 4 are unstable, while type 1 is completely stable. So I think I answered your questions.
Yeah, thank you.
You have observed that there is an odontoid groove, right? So you are discussing whether does it really exist. So you can do CT scan in dry bones of the specimen and just see that whether the odontoid groove really exists and how many specimens it exists, and then with anatomical specimen of bone as well as CT scan. That is number one. And number two question which we arose to both of us, like odontoid groove, does it really correspond to your attachment of the transverse atlantal ligament? So other suggestion is you can do fusion study of CT and MRI, and with special sequence, stir sequence, to look for the ligament, and then see whether the ligament, how much exactly fits into the odontoid groove. So that, I think, you can
Definitely,
take
sir. I
the
concur
next
with
step.
that. When we started the study, these two questions did came in our mind. That is why in the initial part, we first studied all the normal CTs. What I showed there was when I was doing residency, I got these 4 patients in the beginning, and what I could observe was all of them had that odontoid groove. Now the second question is, does it correlate with the this thing with the transverse atlantal ligament? So I searched the literature where they actually confirmed it. There's a paper by Punjabi et al. Where they have confirmed that this odontoid groove is actually the impression of TAL, and definitely in next of the studies we'll be using the CT with MRI to definitely.
All the best.
Thank you, sir.
Thank you. There's two queries for Dr. Chirag. Dr. Chirag, that's a good concept for hinge, but can you let us know what was the deciding factor in the post-op during the intra-op to decide whether to keep the hinge? Any definition for measuring the bulge, or was it subjective feel of the surgeon?
Okay, so the grading of brain bulge is objective. If it is severe, we left the bone flap out.
Okay.
But for mild and moderate, until the point of the outer table, if it is reaching up till there,
Okay.
so that's when we decided whether to do a hinge craniotomy or a decompressive craniotomy.
And did you feel any issues post-operatively of the cosmesis, the loose feel of the skull flap? Because sometimes brain edema takes some time, and the fusion of the brain cannot happen sometimes, and the loose feel is always there with some patients. So was there an issue with that?
Right. So in this study, out of 24, 16 patients are surviving, and I was able to get, I think, 7 or 8 to come for follow-up, so I could see what the cosmesis was like. So in these patients, I do not find that problem, but we have done 300 patients of hinge craniotomy, so we are evaluating that data also. And I have found that maybe up till this point, maybe 4 or 5 patients do have a little bit of a loose bone, but I think 4 or 5 in a patient, that data, with such a large data, might not be such a bad.
You should continue this so that further things.
We need more data. Yes.
Thank you.
My question to Dr. Chirag, that the first slide that you showed, that thick SDH and brain bulge, is there something wrong with your operative technique that after evacuating SDH we don't see that early bulge first, or they are from different patients? Okay. Second thing is that having 33% mortality in mild to moderate head injuries, in which you are doing hinge craniotomy, it is very high. It is, even if you take only severe, then also the head injury mortality is not that high. So is it because the death group, you didn't consider the removal of bone flap that caused the death? Or did you regret any point that I should not have did this hinge craniotomy in these patients?
Okay, so I think the confusion arises from the idea that we have not done it for mild and moderate traumatic brain injury. We have done it for mild and moderate brain bulge. So the average GCS of the patients who underwent both surgeries was 7. So that falls under severe traumatic brain injury. And I think for severe traumatic brain injury, death rate of about 30 to 50% is more or less expected for both groups. I don't think at any point of time we regretted doing a hinge craniotomy, because honestly speaking, what all studies have shown and what our study, both the studies have shown, is outcomes are better with hinge craniotomy and you're able to avoid a second surgery.
The first slide is from same patient?
First slide is from the same patient, and the reason for that is when acute subdural happens, it is the most traumatizing injury that a brain can develop. And usually with an acute subdural, you're going to have some component of a diffuse axonal injury and diffuse cerebral edema. So not all patients have a lax brain. Some patients do have a lax brain if they have only acute subdural. Some patients do have diffuse cerebral edema and they do develop brain bulges.
I think, can you tell that what happened in that patient? Why this much of brain bulge? Particularly because I haven't seen immediately that much of brain bulge. In acute SDH of more than 2 centimeter thickness after evacuation, there is no brain bulge.
I honestly can say that I have operated on more than 100 cases of acute subdural, and there are many times that brain bulges are seen. Not all cases have a lax brain.
Because in a scan there was no contusion, only clean case SDH. If you evacuate it, I think you can easily replace bone in such cases.
It would seem
not
like
even
yes.
hinge, complete bone you can replace.
It would seem like that, but intraoperatively, brain can bulge. Yes.
So basically, not only brain bulge, handling of brain, opening dura, not injuring the brain, these techniques, the basic skills should also be considered.
I think that's important, yes.
I have a question. Alternatives to decompression are being studied routinely. So, for example, rescue SDH evaluated just placing the bone flap back, and also cisternostomy has been coming up recently. So, what is your experience with cisternostomy and replacing the bone flap rather than putting a loose bone flap back, which might not fuse, and the patient might have some cosmetic problems, as you have alluded to, and also because there is a loose bone flap under the skin, closing the wound of a decompression when we do it routinely, even we know sometimes it can be challenging, and having a loose bone flap beneath the skin flap can make the closure even more difficult if it secondarily bulges later on, because even secondary brain bulge can happen. So cisternostomy as an alternative has been thought of by some people. So what is your experience with it, and are you considering evaluating it in the future? With cisternostomy, there is an ongoing study at our center. There definitely is. Yes.
I'm sorry, I think we are going out of topic here. As the chair, I would like to end this session as well, because in the interest of time, and I believe some of you would want to enter the MCQ session. With this, I would like to thank everyone who have presented, as well as the audience who have come up with tremendously good, eloquent questions. And let's hope we progress further from this. Thank you very much.
Thank you to all the speakers. Last session now on neurocritical care and basic neurosciences. I would like to call upon the chairpersons for the same, Dr. Roberto Stefani, Director of Operative Unit of Neurosurgery at the West Milan ASST Hospital of Legnano, Milan. We welcome you, sir. Dr. Amit Thapa, Professor, Head of Department Neurological Surgery, KMCTH, Kathmandu, Nepal. And Dr. V.K. Parashar, ex-HOD, Department of Anesthesia and Critical Care, STMH Hospital, Jaipur. Thank you for being with us, sir.
So welcome everyone. Though this is the last session of the day, I think this is a very important session, and I see a very good line of speakers with us. So without any further delay, I will request Dr. Matthew Joseph from CMC Vellore. He will be presenting on auto regulation after TBI. Dr. Joseph. So we may allow one question after the talk, and then we take the calls and the discussion. After each topic, you have to allow only one question, and then we can take the last of the discussion.
Hello. Yeah, it's working.
Yeah.
Right. So, good morning. I have two apologies to make. One is the casual outfit. I'm leaving straight from here to the airport. Two is I thought it was a 15-minute talk. So I'm going to rush parts of it. Please forgive me for that. Okay, so this is roughly the topics I'm going to cover. Don't worry, it'll go through fairly fast. Autoregulation is basically the ability of the brain to maintain a constant blood flow in spite of varying perfusion pressures. All right, that is basically autoregulation. So, anybody answers? 1, 2, 3, 4? 1, 2, 3, 4, any answers? 1? Anybody for 2? Okay, actually it's both. If you look at it, if you say normal ICP is 10, then both are correct. Okay. The reason I mention it is because this you see in graphs. When you see all those graphs of water regulation, they put blood pressure versus CPP. It doesn't matter. They're fairly close to each other. All of you know this graph. Until the autoregulated range is reached, vessels are maximally dilated to allow blood to go through to the brain. Once the autoregulated pressure is reached and too much blood starts going to the brain, the vessels slowly constrict. Okay, this is a standard picture you'd see anywhere. The physics is complicated. I don't understand most of it, so I'm not going to try and tell you, but if you want to know, that's what the physics looks like. There are many, many things that affect autoregulation. There are a huge number of things that do it. I'm going to just focus on the two things that we can control in the ICU, which is the CPP and the carbon dioxide. I'm not going to deal with the rest of it. Okay, so question number 2. CPP is in the autoregulatory range, but autoregulation is not working. Blood pressure goes up, will cause 1, 2, 3. Rise in ICP, correct. Because autoregulation is not there, as the blood pressure goes up, the vessels will dilate. And therefore, the total volume of blood in the head goes up and ICP goes up. Same question, but autoregulation is intact. Autoregulation is intact, blood pressure goes up. What will happen to ICP? ICP will 1, 2, 3.
They're saying 2.
It will drop, correct. It will drop because as the blood pressure goes up, within the autoregulated range, when autoregulation is intact, the blood vessel starts constricting. When all the blood vessels constrict, the volume of blood in the head is reduced, and therefore the ICP comes down. All right? This is not an immediate process. If you look at it, if it happens over a few minutes, it's perfect. If it happens over if BP suddenly drops or suddenly goes up, there is a period when it doesn't compensate, which is the graph on the right side. It's almost as if you can stand still. You know, if somebody pushes you gently, you stay where you are. If suddenly somebody pushes you, you sort of take a couple of steps back and then come back to where you were. You know, that's the static versus the dynamic autoregulation. Many theories of how autoregulation takes place. The very fact that there are many theories means nobody knows. All right? It's probably a combination, varying contributions to any of these 4 mechanisms. Okay, done with blood pressure. Carbon dioxide. Patient has hypercapnia. Okay, you know that graph, that, you know, this. Where does this point go if the patient has hypercapnia? This way or this way? patient has hypercapnia.
3.
Yeah. 1, 2, 3. Okay. 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 Because normally vasoconstriction will take place, say, at 60. But now you have a powerful vasodilatory effect of hypercarbia. So autoregulation is saying constrict, carbon dioxide is saying dilate. And therefore, the eventual constriction happens at a higher pressure because of the vasodilatory power of carbon dioxide. Okay, if you look at the graph, I don't know if my cursor comes. Yeah, it does. Okay, so normal would be here. Vasoconstriction takes place only here when there's hypercarbia, because hypercarbia is dilating the vessel. Blood pressure is trying to constrict the vessel. Autoregulation is trying to constrict the vessel. So in the fight, it sort of gets pushed higher up. Opposite way. Hypocapnia. Now we're talking about the other end of the graph, which is here, and when passive vasodilatation takes place. What would hypocapnia do to that point? Move it left, move it right, or leave it where it is? Again, answer is higher pressure. Because when you look at it, now coming down, at whatever, 150, the vessel is supposed to start dilating. But here now you have a powerful vasoconstrictory effect, which is hypocarbia. Hypocarbia causes severe vasoconstriction. So blood pressure is trying to dilate the artery, carbon dioxide is making the artery scrunch up, and therefore the end result is you get a shift to the right. Okay? Chronic changes would move your graph to the right. Okay, chronically this thing, your point at which vasodilatation takes place, point at which vasoconstriction takes place, would move to the right as this whole vascular system adapts. Many, many ways of trying to measure autoregulation. None of them is perfect, which is why there are so many ways of doing it. This concept is gaining popularity. Okay, basically, which the point is, the ideal CPP for a patient varies from time to time, varies between patients. So you can't prescribe a number and say this is good CPP for all patients at all times. All right. If you look at it, if somebody whose autoregulation is intact, as the BP goes up, the vessel is constricting and the ICP is coming down till this certain point, which you can call the optimum CPP, when the vessel is maximally vasoconstricted, beyond which passive vasodilatation starts taking place. BP starts going up because BP is too high. Okay, you want to be somewhere around here with your CPP at any given time. Okay, if autoregulation is impaired, obviously that doesn't work very well. So you need to figure out where the CPP should be, which is kind of hard. We do a very crude system in our hospital, which is I come in the morning, and if there's no contraindication, I up the noradrenaline and see what happens to the ICP. BP goes up by 20, look at the ICP. ICP goes up, autoregulation not good. Today is a control the ICP day. BP comes down a little bit, autoregulation is there. Today is a don't give too much hypertonic saline mannitol, just maintain the BP in a good CPP range. Yes, I do a crude autoregulation testing, but it's much better available now, at least if you can afford to buy the ICM Plus software from Cambridge. So, excuse me, if you take these two patients, the green patient needs a higher CPP than the blue patient. If you took the blue patient to green, he'd be starting passive vasodilatation. You leave the green patient at blue, there is vasoconstriction you left behind. Okay, which is why you need the CPP op software, which, I mean, we can't afford, so we don't have it, but if you can, it would be nice to have. Pressure reactivity index has not been shown to affect, you can't You can predict death to a certain extent. A positive PRX means when the BP goes up, the ICP goes up. That's positive, which is bad. Negative is good, which means auto-regulation is intact. All right? So the one thing you must remember about this is that, yeah, this is my last slide, is that no patient with significant injury is either completely lost auto-regulation or has completely intact auto-regulation. So what you're looking at when you say auto-regulation preserved, auto-regulation lost, is actually the balance. Is the majority of the brain got auto-regulation or not? That's what you're looking at. Thank you.
You can allow one question, and he is also in hurry.
Yeah, sorry, I mean, I wasn't expecting to be in the last session, which is why I sort of rushed through my presentation a little bit, because I initially thought I had 15 minutes.
If none, I have a question to you. Since you have done a lot of things on CO2 reactivity, like how long do you think that CO2 control will have an effect on the patient? So we play with the ventilator to decrease the CO2 or increase the CO2. How long will that effect persist?
Okay, so we know that using carbon dioxide to control ICP is a bad idea. I mean, bringing the carbon dioxide down to bring the ICP down is a bad idea, okay? Because it causes ischemia to the brain and it doesn't last very long. Within 24 hours, you're back to the same blood volume we had before, okay? When we started doing ICP monitoring, what we found is our commonest alarm was because carbon dioxide was going up. Okay, I think preventing hypercarbia is very, very useful in the management of these patients. Okay, electively bringing down carbon dioxide, not so much. We never do that. You know, I think the lowest we would electively bring down is maybe 33 millimeters, not below that.
Yeah, safest should be between 35 to 40.
Yes.
In these patients. So. Point well taken. Yeah.
Okay.
Thank you.
Thank you. Thank you. Thank you. Thank you all.
Second speaker, I call to Dr. Mathu Kumar. Timing of surgery in spinal injury, a systematic review. Dr. Kumar.
Morning, thanks for the opportunity. Can you get my slides on the, yeah. So this topic is entirely going to be a presentation based on the evidence available in the literature, and it does not certainly reflect my personal preference or my pattern of practice. So these are the areas which are going to discuss. Why is spinal injury important? Why early surgery for spinal cord injury? How early is early? How do you define that? Is the timing of surgery same for all levels of spinal cord injury? Is it same for all types of spinal cord injury like complete, incomplete, and central cord syndrome? I'm going to skip two of the questions like the timing of spinal cord injury for patients with polytrauma and economic consequences of the timing of surgery because of time constraints. The last question we are going to address is it possible to practice what is being published in the literature? We all know the spinal cord injury is increasing worldwide and it causes tremendous socioeconomic impact. And why should we discuss this topic at all? Because to promote standardization of care and to enable surgeons to make evidence-based decisions. And we need to understand it is a heterogeneous entity where younger patients tend to suffer high energy injuries, whereas the older patients tend to suffer low energy injuries. And spinal cord injury as such is not a homogeneous entity because patients have complete, incomplete spinal cord injury and central cord syndrome, all the three of which have different prognostic implications. Now, the concept of primary injury and secondary injury is same for brain and spinal cord injury. And the primary injury initiates a sequence of biochemical events that aggravates the secondary injury, causes secondary injury, and the aim of our treatment is to alleviate the secondary injury because we can't do anything about the primary injury. Why is early surgery? Because there is compelling experimental evidence to suggest that early surgery does good, and persistent compression on the cord is a reversible form of secondary injury. The advantages of early surgery is that it promotes early mobilization, length of stay in the ICU and hospital is reduced, and the complications also reduced. Probably the mortality might be reduced also. The disadvantage is that you might end up operating at suboptimal hours with suboptimal setup, and the associated trauma might get worsened. The polytrauma, especially if it's associated, it might suffer a second insult. Now, this is the area which the literature is absolutely, the absolute confusion in the literature. Nobody defines what constitutes early spinal cord injury. Generally, most articles use 24 hours as a cutoff, but there are varying definitions varying from 8 hours, 12 hours, 36 hours, even up to 72 hours, and none of these articles mention why they have chosen this particular cutoff point. What is the sanctity about this cutoff point? This is a status trial, well-known prospective multicenter study in 6 North American centers where 313 patients were recruited. The ASIA score was used as the primary outcome measure. And what they found was when early surgery, when 2-grade improvement in ASIA score was used, early surgery was found to be beneficial. Whereas when the primary outcome measure was a 1-grade improvement in the ASIA scale, there is no difference between early and late surgery, even though the early surgery had slightly lesser rate of complications. But this trial, like many other trials, had its own limitations. It was a non-randomized study. Possibly there was a selection bias. Patients with polytrauma were excluded. And early surgery had younger patients who would have more likely had less comorbidities, and late surgery had more complete injuries, which means inherently they are predisposed to have bad outcome. Other limitation being almost a quarter of the patients were lost for follow-up, and this study was conducted in tertiary centers. Whether it's applicable to all centers across the spectrum is a matter of debate. This is an excellent study from a Canadian multicenter study based on the recurrence and spinal cord injury registry, 31 sites in 15 Canadian cities with 1,400 patients. Basically, the conclusion is in incomplete spinal cord injury, early surgery is beneficial, not so in complete spinal cord injury. Now, there is that ultra surgery useful because there's a scientific basis for ultra early surgery because the ischemia, edema, and necrosis reaches a maximum within 8 hours. So it should be theoretically beneficial. And this meta-analysis of the literature showed of 273 patients showed that in outcome is certainly better in and the length of stay in the hospital is shorter in but there is no difference in the complication rate. But look at the other study which was published in Neurosurgery 2018 where only the cervical spinal cord injury is included. The cutoff point was used as 12 hours. They showed if the patients are operated within 12 hours, the patients have at least 1-grade improvement in the ASIA score. But beyond 12 hours, even within 24 hours, there was no such improvement. But now let's come to the next concept of traumatic central cord syndrome, which usually happens in the setting of a pre-existing secondary canal stenosis. There is absolute confusion in the literature regarding the timing of surgery in central cord syndrome. The AO guidelines, AO spine guidelines published in Global Spine Journal 2017 says that early decompression is beneficial for Asia grade C injuries and late decompression is an option for Asia grade D injuries. They are silent about what to do for patients with Asia grade A and Asia B. This is a recent multi-center study. 183 patients were studied using propensity score matching, and what they found is the 24 hours was used as a cutoff point. In early surgery, improved the upper extremity motor score, but not the lower extremity motor score. Now compare this with another study in 2023 from Japan, where 159 patients were studied, but the cutoff point for some reason was used as 48 hours. They found the early surgery did not show positive influence on the outcome. This is the confusion in the literature. There are contradictory results. Is there a difference in the outcome between early and late cohorts vis-a-vis the level of injury? Yes, in cervical injury, early surgery is certainly beneficial. In thoracolumbar injury, probably there is no difference between early and late surgery. But in both in the cervical and thoracic cohort, the complications, the length of stay in the ICU and hospital are much less with early surgery than in late surgery, but not so in the lumbar cohort. Now we come to the most important question. Is it possible to practice what we preach? Now look at the data from North America. This is a nationwide inpatient survey in 2013. Only 30% of patients with acute traumatic cervical cord syndrome underwent surgery within 24 hours, the median time being 3 hours, 3 days. In another study, once again from the National Traumatic Comorbidity Bank, where 2,600 patients, one-third had complete, one-third had incomplete, nearly one-third had central cord syndrome, and only 44% of the patients underwent surgery within 24 hours. Most of the delays occurred not during because of transfer, but after admission to the hospital. And this is a reality of accomplishing surgery within 24 hours for complete spinal cord injury. 24 hours is used as a cutoff. 2,800 patients in 353 North American centers, only 61% underwent surgery within 24 hours. Either the patient characteristic or the level of hospital did not matter. Now, this is a Rick Hansen spinal cord injury. This is a beautiful study where they measured the difference between ideal and actual time. What surgeons wanted to do, what they were actually able to do. More than 95% of surgeons wanted to operate early, but they were able to do practice what they wanted only in less than 30 to 40% of patients, because we may want to operate early, but it might not be possible because of logistic and other reasons. And this is an excellent study. This is the only study in the literature. This is from Michael Felling's group, where there's an arbitrary cutoff point was not taken like 8 hours, 12 hours, or 24 hours. Time from injury to surgery was used as a continuous variable, and they found when the surgery was delayed beyond 24 to 36 hours, there's a precipitous decline in the outcome. Now, the key takeaway messages are there is some level 2 and level 3 evidence to suggest that early surgery is useful, at least for incomplete spinal cord injury. So, the concept time is spine might apply for incomplete cervical spinal injuries. Early surgery is probably effective in thoracic spinal cord injury, at least in reducing the complication rate and length of stay in the ICU and hospital, not so for early and late spinal injuries. Now, all these studies are vitiated by the fact that all these studies use ASIA's grading as the only outcome measure. Like in cervical spondylotic myelopathy, where you have a definition for minimal clinically important difference. For example, in severe myelopathy, the MCD should be an improvement of score of GIS score of more than 3. For moderate, it should be 2. For severe, it should be 1. Like that, we don't have what constitutes a minimal clinically important difference for spinal cord injury. This is absolutely required. And apart from ASIA score, we should have other measures to measure the outcome, like functional independent measures as an ordinal scale. So if we do this in future studies, we will be able to identify a subset of patients who will benefit from early surgery, and the limited resources that are available can be used for the benefit of patients who have greater chance of improving. Thank you very much.
Thank you. Any questions?
Yes, doctor.
When we talk of early surgery, means fixation as well, or just decompressive anatomy for central cord syndrome?
Pardon? For central cord syndrome. They have not mentioned in the literature as such, they do not mention whether it's just decompression as such or instrumentation, but I believe the current tendency is to do decompression with instrumentation. The current tendency worldwide is to do decompression with instrumentation.
When it comes to feasibility, like decompression can be done like EDH, like any early surgery, but when it comes to fixation, then I don't think feasibility of doing that early is there.
With an injured cervical spine where there's a potential instability, personally I would be very much reluctant to do just a decompressive laminectomy. I would be personally reluctant to do it, and in experienced hands, placing 4 screws this side and 4 lateral mass screws on the other side will hardly take 20 minutes. It does not even require.
It's not time, it's availability of technician and odd hours to do
That is exactly what I pointed out. That is the reason. That is absolutely, you are absolutely right. That is the reason I pointed out worldwide, even in advanced countries with state-of-the-art medical care, they are not able to operate within 24 hours. Hardly 30-40% of patients are being operated because of limitations, practical logistical limitations. It's a very valid question. I agree.
Okay. I think this is the key point. When you say surgery, which kind of surgery, minimally invasive surgery, how is the blood loss? And so it's very difficult to say just surgery.
Most of the studies, they do not talk about minimally invasive surgery. They talk about either upper anterior reduction or a posterior or 360 degree. The question of minimally invasive does not come in this particular. Most of these studies talk about the conventional open surgery only.
Okay, thank you.
May I invite Dr. Amit Thapa?
No.
Okay. Oh, so I'm sorry. Mr. Lachisolino, he will talk about quantitative evaluation of head injury using CD dimers.
Thank you for
Thank you for kind introduction, Chairman. And thank you for giving me this great opportunity. So the organization of this meeting. So today I will talk about the quantitative evaluation of head injury using serum D-dimer levels. As you all know, aging of society is becoming a social problem, especially in developed countries. In recent years, the aging rate of head injury patients in Japan has exceeded 50%, and more than half of head injury patients are elderly. In other words, we have to adapt to head injury in the elderly. Here are the characteristics of elderly head injury patients. First, the subdural space expands due to brain atrophy. This increases the mobility of the cerebral hemisphere and causes damage to the bridging vein. Furthermore, symptoms due to intracranial hemorrhage do not appear immediately after injury. As shown here, even if elderly people are conscious, they are more likely to show abnormal finding of head CT. In elderly patients with head injuries, it is not possible to determine the presence or absence of intracranial hemorrhage at the level of consciousness at the time of examination. If the presence of intracranial hemorrhage is not revealed on examination, CT scan would have to be performed on all head injury in older adults. But that's not the reality. As shown here, there are various adverse effects of head CT imaging. In other words, we need an efficient method for determining the necessity of head CT in patients with head injury in the elderly. Therefore, we made this determination using serum D-dimer. The subject were 88 patients with mild TBI, and we excluded those treated with oral antithrombotic drugs or cancer patients. And as a result, 73 patients were included in this study. Patients were classified into two groups. So number one, region positive group is a patient with intracranial hemorrhage or skull fracture based on CT scan at admission and follow-up CT or MRI. And the number two, region negative group is a patient without those findings. And the blood test findings, FDP and D-dimer on admission were compared between the two groups. This is a result. So you can see that the value of FDP and D-dimer in the region plus positive group is significantly higher than the value of in the group of region negative. When ROC analysis was performed, high sensitivity and specificity were obtained with a cutoff value of 1.7. So my suggestion is that coagulopathy and abnormal fibrolysis, so for example, D-dimer or FDP, are measurable in routine medical practice. And the D-dimer and the FDP are associated with intracranial hemorrhage or skull fracture in mild TBI. And measuring coagulopathy could be useful as a screening tool for CT finding after mild TBI. There is another problem with head injury in the elderly. The problem is that there is a high rate of deterioration in the geriatric TBI patients. Previous reports indicated that approximately 10 to 20% of mild to moderate head injury progress to coma, and 7% require surgery. In other words, it's important to treat early in case of head injury in the elderly. Therefore, it's necessary to develop a method to predict this deterioration. Here,
we focus on D-dimer again. So this next study, the subject was 61 patients with mild to moderate TBI, and we excluded the same condition. And 54 patients were included in this study. And patients were classified into two groups. Operation positive group is a patient with deterioration requiring surgery. And the operation negative group is a patient without this condition. And blood test findings, FDP and D-dimer compared again. So you can see that the value of FDP and the D-dimer is significantly higher in the operation positive group again. So this is my suggestion too. Although TBI was mild or moderate, coagulopathy as biomarker was noted at significantly higher rate in the patients called talk and deteriorate. Post-hospital management can be determined using the serum D-dimer level at the admission. However, the mechanism by which D-dimer level increased due to head trauma is unknown. Possible mechanisms include dilution of coagulation factors by intravenous fluids or activation of protein C triggered by hypertension. However, our subject is mild head injury, and these situations do not apply. So therefore, we investigated the relationship between D-dimer and the tissue factor. So 9 patients with moderate to severe isolated TBI were included in this study, and we collected blood sample from artery on arrival in the emergency. The concentration of NSC, D-dimer, and the tissue factor in serum were measured. And the correlation between NSC and D-dimer was studied in confirmation of D-dimer as biomarker for brain damage. And the correlation between D-dimer and the tissue factor was also studied in confirmation of tissue factor as trigger of D-dimer elevation. So this is the result. The significant correlation between NSC and D-dimer is, so you can see that the significant correlation between the two groups. And you can see that significant correlation between tissue factor and the D-dimer. So I will explain the mechanism of the relationship between D-dimer and tissue factor. Brain is an organization with rich tissue factor. So traumatic brain injury induced the release of a tissue factor, and it induced that thrombin burst. And this thrombin burst induced activate brain protein C, and it's induced that inhibition of PI1. And after that, so finally, it induced hyperfibrolysis and elevated D-dimer. So my suggestion 3, the level of blood D-dimer accurately reflected the degree of brain damage indicated by NSC levels. Our data suggests that the release of tissue factor induced by brain damage may activate the coagulation cascade leading to elevation in D-dimer levels. Conclusion, early symptoms are difficult to appear in the geriatric head injuries. It's important to be able to anticipate deterioration and respond quickly in the treatment of head injury in the elderly. The serum D-dimer level at the time of delivery is useful as a predictor for the above two items. This biomarker is inexpensive and highly versatile in daily clinical practice. Thank you for your attention.
No, it's a very nice concept. My question is there a difference in the D-dimer levels depending upon the type of pathology? For example, a patient with diffuse axonal injury versus a patient with extensive parenchymal contusion, because a patient with extensive parenchymal contusion or a patient with external hematoma is less likely to have brain injury, whereas a patient with extensive parenchymal condition is more likely to have the thrombin burst issue. So have you noticed the difference between the type of pathology and the D-dimer levels?
Yeah, so your opinion is exactly right. And so I'm sorry. So I cannot. I have not analyzed this detail, but my feeling is axonal injury is not so high D-dimer, and actual brain damage is elevated D-dimer. Thank you.
I see your exclusion criteria is coagulopathy, so patient under antithrombotic therapy, of course. What I have to ask, there is a cutoff of the DMAR value to understand when you start this problem, or is a trend that we have to check? So if it's a trend, how many times we have to measure the DMAR to understand that it will prognostic factor?
Yeah, I'm sorry. So I have not measured seriously. I mean, we measure just one time at admission, but this this point is that we can determine just at the admission time. But I agree with you. So we should repeat the measurement. And my friend is my different group in Japan measures like that. And but 3 hours after injury is a peak of D-dimer, and after that it's decreasing. So I think it's not need to repeat a measurement. So I can determine.
So if after 3 hours or within 3 hours from brain injury, the D-dimer is higher than normal value,
yeah, that's right.
The prognostic factor.
Yeah, that's
so
right.
People come in that group.
Yeah.
Thank you.
Thank you. I want to ask you, your exclusion group was the people who are using anticoagulants and do you think it is only for head injury if there is a long bone fracture, suppose, if it is a polytrauma patient, then also it can, D-dimer can raise because of that. So it is only isolated head injury, or in polytrauma also we can apply this thing?
Yeah. I'm sorry, I couldn't understand.
So
but
suppose this patient is having a femur fracture associated with head injury, then also D-dimer, you will considering the same thing?
Yes, yeah. I will talk about later. So I'm sorry. Thank you.
Thank you. I call our co-chairman, Professor Amit Tapa, improving surveillance of neurotrauma patients inside ICU using point of care, I think.
Thank you, chairpersons. Before I start this talk, may I have a show of hand as to how many of us in this audience uses ultrasound in their ICU? Yeah, great. This presentation would definitely incite you to use ultrasound in your ICU if in case you are not. And if you're using it, then I'm actually presenting a method of a systematic way of using it as a surveillance in ICU. And I have nothing to disclose in this presentation. And so I just give a clinical scenario to set up the stage. It is a 34-year-old gentleman who underwent a recent decompressive connectomy for a severe head injury. Post-op, he seems to have a brain swelling, and because of the blood pressure, low blood pressure, he could not be shifted to a CT scan to look at as to what is happening to his brain. But then there is a bilateral swelling in the eye, so you cannot even evaluate his pupillary response. So this becomes a clinical dilemma, which I think is fairly common in our ICUs. And there is the problem, how to evaluate the patient, whether the patient would require another increase in the medical care or another step up of the raised in ICP control. So these questions can be very easily answered if one uses ultrasound in their ICU, and I'm going to present on that as to how we do it. So POCUS, or point of care ultrasound, is the way we use ultrasound at the bedside, and it is performed by the end user, that is the clinicians himself or herself. It has been found to be very cost effective and a non-invasive procedure. It provides a real-time information and more specific in diagnosis and therapeutic utilities. It is fairly different from the way an ultrasound does. Why? Because you have a yes or no answer to your problems. You want to see whether the patient has a pneumothorax, yes or no. That's it. You're not doing a complete survey of organs with an ultrasound in your ICU. And what we have been doing is that we have been teaching this ultrasound, and we have been using this point of care ultrasound in various of the arenas in our neurosurgical practice, be it in TROP or ICU or OPD. In this talk, I will be restraining myself to the ICU care. The probes, which there are many, we are usually use only 3 probes, that is a curvilinear, linear, and if in case it's possible, an echocardiography probe. So that 3 probes actually suffices for all of your scanning. Now, we also published this work in the recent Quantitative Imaging Medicine Journal, and where we have found that because of use of POCUS, we can actually intervene timely and adequately in 26% of the cases who were evaluated. Mind you, these were the numbers who had been easily missed if in case we have dependent upon the clinical examination. So this much was a very statistically significant number for us, and that's how we could actually make a point that this should be used. Now, POCUS can be used not only to primarily resuscitate the patient, but also for daily secondary survey. So what you're looking at is the optic nerve sheath diameter, transfontanine evaluation if in case it happens to be a neonate, transcranial Doppler. We are doing a screening for DVT scanning. We are doing a VP functional test. The paper on this is also coming up very recently. And then a transcranial defect ultrasound, because the patient would already have a bone removed. So you can even scan the brain, which gives you an image as good as an MRI. And then a focus ultrasound like a blue protocol, particularly those patients who are having cyanosis. You can even try to find out as to what is the reason for that. So that's called as blue protocol. And then evaluation for hemodynamic shock. And then we even use it for placing like CVP lines, difficult cannulation, and pleural and transfontanal tapping. Now, what we are doing at my center is a protocol-based or a systematic pattern. So on the left is basically a chart, and I'm just dividing into 2 parts. So we identify the patient's detail, and then we go systematically from head to toe. So we do an ONSD recording. This is done every day. Then we do a TCD recording if in case patient has an aneurysm or so. However, if in case he does not have even a traumatic IC patient is also mandatory to do that. And then we do a DVT scanning every day, transfontanal if in case it happens to be a baby with an open fontanelle. Then we do a blue protocol. Then this is again mandatory because in my ICU, we do not do a regular chest X-ray examination. We just use an ultrasound. If in case we find any opacity, then only we ask for the chest X-ray. And then we do for an IVC calibration to see whether the patient is hemodynamically well resuscitated or not. This is not important, or rather not applicable for those people who are on ventilator, but then of course those patients who are free of ventilator, they can be used with that. VP functioning testing, VP shunt functioning can be tested, transdefect in ultrasound, EFAST, and then evaluation for shock hypoxia assistance during CPR and a sonosopic guided procedure as per what is required. Now, point by point we will cover. So optic nerve sheath diameter is measured 3 millimeter behind the retina, and we look for the diameter of the opacity is created, and it actually correlates in our population that more than 5 millimeter thickness of ONSD correlates with more than 20 millimeter of mercury in ICP, and the sensitivity is more than 94% and specificity is 98%. And we have already done a study published on this on a normal population in Nepal. So in the European literature, it is like 6 millimeter, but in our population, it shows to be around 5 millimeter. Other than that, we can use an M mode for the pupillary movement. So this is very useful when those patients where the eyes cannot be open because of periorbital swelling. So you can actually measure the diameter of the lens or the pupil by using an M mode in these patients. And then transfontanal ultrasound, as we all know, it can give you a peep inside the brain. In adults, we can even use a transternal window. But then in my population in Nepal, people have a very thick temporal bone, and that's why it does not give us a very good acoustic window to scan the brain. Then transcranial Doppler, we all know it. We actually look for the velocities and then compare it with the carotid in the neck. VP shunt patency is something which we have mooted. This idea actually has three elements. So what we are looking at, the flow of the CSF through the tube, 2 centimeter proximal and distal to the shunt reservoir as we compress it, and we can chart the velocity. And then the third element we are looking at is the free fluid in the abdomen. If in case we see all these three elements present, then we concur that the patient is having a well-functioning VP shunt. It will not tell you whether the shunt is over-functioning or under-functioning, but it will definitely tell you that this shunt is having a good function. So that's something which we also like to see in our ICUs. And then the trans-defect ultrasound for any edema, for any hematomas, for brain shift. These actually gives a very good idea as to what is happening in the other side of the brain, which we have not operated upon. This is very useful in patients with multiple contusions or the contralateral hematomas, which we are thinking to be minor, but then the course of the duration may actually increase. And that's where the role of surveillance comes into the picture. So these are some photos of a transcranial defect ultrasound as we do it. Now, Blue protocol was actually mooted by Lichtenstein in a 2008 paper, which was published in Chest. And this is a very beautiful paper, which actually profiles all the lung ultrasound. They actually point out 10 characteristics, features to be looked for. And it hardly requires 3 minutes to identify the patient, or using a POCUS, what is the reason for the patient to have a cyanosis or the decrease in the oxygenation as such. And then DVT screening, particularly in the lower limbs, is very helpful. Even though we are using pneumatic stockings in all the patients, we have been doing it because in the neurosurgical ICU, as you all are aware, we are very much skeptical regarding the use of anticoagulants because these patients has bleeded and then or rather had undergone a surgery. So when we adopted this protocol, definitely it was not welcoming. The most important thing was that people were not trained into it. And then the second was that the seniors would not accept the finding of ultrasound, saying that there are many, like it is very operator dependent, and that's why this had a problem. But by teaching a learning modality, we have actually been able to overcome this. And in my place, since the neurosurgical ICU is taken care by the neurosurgeon, it becomes a lot more easier to push. But now I'm told that this is being taken over by even the anesthesiologists, my critical care friends in other ICUs. So that's something which is very welcoming. And what we have studies, it hardly takes more than 10 minutes. And now we have even trained our medical officers to do that. So even it does not require a PG for that matter to do these evaluation. And then they have to document everything, and then they have to actually keep the recordings in the memory of the ultrasound so that this can be checked. So of course, there's a limitation, particularly the operator dependency is very much high, so one has to be trained with it. So how we are doing it in our places, that at least any person who starts doing this focus evaluation has to, first of all, assist one case, then he has to perform at least 10, and then show these 10 recordings to the seniors, and then they can be given a separate chart independently to chop it out. And then, of course, radiologists or the sonographers are required. We like to confirm it because of the medical legal issues. The people can actually say that you are not trained in sonoscopy and why you're reporting it. So for that matter, when we have any positive feature, we always like to second it with one of the sonocopist friends. So this is the teaching learning program which we have been doing it in our places. Multiple courses. I think we have conducted more than 10 courses in the last 10 years. And then we have even published our reports as to how this has been able, these courses have been able to change the perception and also the knowledge of the people using it. And I'm very happy to say that all the participants who are the like participant of these courses have actually taken up focus at their own places. So we have trained emergency physicians, we have trained ICU doctors, we have trained anesthesiologists, we have trained general surgeons, and even our neurosurgical friends, and they have all taken up this particular thing in their practices. And we are now actually trying to make this focus as a part of an undergraduate program. But of course, it requires a lot of effort and a lot of cooperation from different people. So routine systematic use of focus can be beneficial. And for rapid diagnosis and problem management, this is one of the things where your diagnosis and resuscitation can go sideways. And that's why it is very helpful. And you can pick up the problems at a very early stage rather than depending upon a chest X-ray or a CT scan to give you a finding. And it can be very well incorporated into an undergraduate and critical criteria. Thank you for your patience listening.
Thank you very much. My question is, you don't have any PCDNT Act in Nepal? Because here the problem is, one of the biggest problem is the PCNT. For every place you reject, the person has to have a license for that.
So this is very unique problem in India, because nowhere in this world gender identity is not to be
The
revealed to the
data of
parents.
every sonocyte machine are being sent to the government every month. Another thing, how do you know the working of the VP shunt? Do you put the coloring or how?
Oh, this is a completely non-invasive method.
Yeah,
So we
it is
try to look
non-invasive,
for
I know it.
we try to look for the flow of the CSF in the tube.
Okay.
So as we compress, this is one of the clinical tests we all perform in our OPDs.
I know.
So whenever a patient of a shunt comes up, we actually press the chamber. If the chamber compresses very easily, this means there is no forward block. And if in case it is refilling, we know there is no backward block. So same thing we are corroborating by using an ultrasound probe. So by using a Doppler mode, we can see there's a flow, and the flow can be actually seen in numbers. And third element is to look for the free fluid in the abdomen. So if these three things are there, I know that the CSF the shunt is working, and there is some amount of CSF flow in the tube.
Any question?
Yeah, Dr.
Is interesting. So I didn't understand. You check if there is a CSF before and after the valve, and this is even when sometimes happen that the patching valve, it seems that it works, but from a clinical point of view, it doesn't work.
Yeah, thank you for that question. So there is this is actually dependent upon what type of shunt you use. So in our place, we are using Chabra shunt. So Chabra shunt, it does not places the reservoir bang on the burr hole. It has to be kept almost, it is almost 2 to 3 centimeter beyond the burr hole. So that's why you have a space for the tube, which flows underneath the skull for at least 2 to 3 centimeter. Secondly, we have seen in our data that most common cause of the shunt failure or non-functioning shunt is the distal block. So if in case there's a distal block, if we can corroborate that the CSF flows through the tube on compressing the valve, the reservoir, and then we also could help identifying that there is some fluid in the abdomen, free fluid in the abdomen, we can actually say that, okay, CSF is flowing through the tube. So in this study, which we have recently published, in that what we have done is we have actually tried to compare the findings on this focus with the CT scan of the patients after the surgery. And then we have been able to say that, okay, the shunt is functioning in these patients. But this is only for the obstruction of the shunt. This is not to comment upon whether the shunt is functioning in terms of how much CSF it is draining. So it is only give you an answer of yes or no.
Okay.
We use, you use the ultrasound. I just want to know what probe do you use for that in the craniectomy side defect?
It's a curvilinear probe.
So there are 3 probes available.
Yeah, so curvilinear is the convex probe, which has the largest footprint.
Okay.
And the best part is that it has the largest penetration. So what we do is whenever we put a probe on the patient's head, we first of all decrease the depth, and we try to keep the focus under vision. So when we are trying to scan the contralateral brain, then we keep the depth at around 10 to 12 centimeter. If you are looking for the ipsilateral, it is hardly 7 centimeter, which is required.
Okay. Thank you.
Okay, thank you, Professor Tapa. I want to say that ultrasound are a very effective machine, even in a surgical room, remember. Not only in ICU, but in a surgical room. Okay?
No. Who is the next one? Hello.
Thank you.
Okay. Yeah.
Good morning,
So now,
everybody.
Dr. Yogal.
Good morning, everybody. And thanks for the organizing committee for giving me the opportunity to demonstrate our data in terms of infection and cranioplasty. So cranioplasty, usually it's an overlooked procedure, just putting the bone flap back on. What could possibly go wrong? And sometimes, you send your residents there, okay, you do the cranioplasty, just call me when you're done. And it's. So why we are doing cranioplasty generally? Okay, we are doing it to protect the brain. We are doing it for aesthetic repair, especially when you deal with decompression or hemicraniectomy decompression. You have a significant aesthetic value, and it also improves, according to some studies, the motor function in 5 to 10%. Now, the overall complication rate in cranioplasty are pretty high, and it's up to 36% for autologous bone. We'll discuss autologous bone as well as allograft. And previous large series reported a high rate of postoperative complication, most commonly infectious, requiring removal of the bone flap. So in our department, back in 2009, we noticed a very high infection rate post-cranioplasty, about 25%. So we decided to take some action regarding that. There were two studies, the Irish studies and the Italian study. In the Italian study, it's a meta-analysis that pulled together 40 studies. You can see the number here. And the pooled infection rate was 10%, 11% was in TBI patient. And that's the Irish study. The infection level was, or rate, you can see it just in front of you. For autograft, it's 8.3 and 11.3 for allograft. So autologous bone has this rate of infection, and the complication in the short term are, of course, infection, bleeding, surgery, and epilepsy, and in the long term is mostly bone resorption, which is not the topic of our talk. So basically, when you think about that, you need to plan ahead by the time you are doing the decompression. So when we talk about plan ahead, we talk about doing the right size, and we use the size of 10 by 15, just mostly my hand. You put it here, and this is your size of the decompression in trauma. And you plan it in a way that the skin incision will be beyond the craniotomy site, and use the right plan to dissect. And we usually do the dissection with scissor, and we don't use monopolar. We may use bipolar on the flap if we have not small artery that bleed and we close, but generally we don't use in this surgery monopolar at all. So I would like to summarize our experience. So as we said, we had about 25% rate of infection. That was when I started to be the chairman of the department. That was back in 2009, and I decided that we have to do something about it. So I took Professor Rosenthal, and we sit together, and we put a 7-point protocol to reduce the number of our incidence rate of infection. And we looked at autologous bone cranioplasty following unilateral decompression, bifrontal decompression, and the aim, we initiate a strict regimen program attempting to reduce the incidence of postoperative infection following cranioplasty. And I have to tell you that as a chairman, I had to enforce that brutally on the team, because there is a discipline problem, and the patient may pay the price because of that. So that was implemented very, very aggressively, okay? So we studied all patients above the age of 16 that had cranioplasty in our institution. We had a 7-point program, very simplified points. I will go with you together on those points, and there's some double rules within it. So decompressive craniotomy bone flap, we clean and rinse during the original surgery with gentamicin containing solution, and we put it in a double sterile package, and the bone flap was stored in a dedicated minus 80 degrees Celsius freezer with appropriate temperature control and alarms. Make sure that the alarm will work, because if the temperature goes up and the alarm, so you lose all your bone flaps there. So we had that once. So it's very important to make sure that that's a deep freeze is functioning properly, and it is connected to some alarm in the hospital. So what are the points? So preoperative antibiotic dosing, that's obvious. Everybody probably does that. Meticulous wound preparation with double shaving. Double gloving with frequent change the glove during surgery of the cranioplasty. Okay. The 4th point is removal of remaining soft tissue from the bone flap that was not removed in the original surgery. That's cleaned very, very thoughtfully. Okay. And the 5th is placement of subgaleal drain in all the cases, whether JP7 or 10. And after cranioplasty, antibiotic continue until drain removal, and every department may have a different antibiotic protocol. We use Vanco and gentamicin until we remove the drains. And patient and families were instructed in a wound care regimen later on. So we had altogether 107 patients that had 109 cranioplasties, 85 males. You can see the numbers here, mostly for trauma, but also for ischemic stroke and post tumor removal. We had 96 unilateral on the right. On the left, 8 patients underwent bifrontal cranioplasty and 3 patients underwent bilateral. We can see it here. And the surgery, usually the timing was the mean 4 months after previous surgery, and mean of 5 days of hospitalization, and no 90-day postoperative mortality in this series, and the infection rate in this number, we have 2 cases, so it's 1.8%. 4 patients require reoperation, and bone flap was replaced in all cases, and the reason was due to epidural hematoma. We had 3 focal seizures, 5 generalized seizures, 1 pneumonia, and no event of DVT, PE, or cardiac event in this group of patients. Well, at that time, we also studied some other thing, and the bone resorption rate in our group was about 10%. So if we look at the literature, no difference complication rate for synthetic implants and autologous. We use the PIC as synthetic in cases that the bone is not available, or there are some reason why we use the PIC synthetic one. So we had 38 patients underwent 38 cranioplasty with PIC. Mostly unilateral, but 2 were bifrontal, and the infection rate in this group was 2.6. What make it's 3 out of. So basically, if we pull the numbers together, the infection rate is 2%, which is compatible with some other result. Definitely much more better than 25%. You know, it's 25%. It may be a little more. I don't know. It was just an estimation of 25%. So we were able to take it down to 2% altogether. So we have here the infection rate that we can see here for allograft and autograft in the Irish study, as well as and you can see here the bone resorption. This is the number that we have. And to conclude, implementing a regimen program to reduce infection may help to achieve a low rate of post-surgical infection requiring revision surgery regarding cranioplasties, infection rate of 2%. Our complications include postoperative hematoma, seizures, and hydrocephalus should be anticipated. Bone resorption should be taken into consideration, and follow closely for bone resorption. As we know, 10% of them will do, in autologous bone will do resorption. Plan ahead and do not do the decompression right. This is a very important point, and it's also rewarding in terms. It's a rewarding surgery generally. You can see this girl that was had a huge hemicraniectomy, and following surgery with a pretty good aesthetic result. And of course, we should anticipate a complication. And I thank you for your attention.
Any questions here, Dr. Dhawan?
I can hardly see you, Shukla.
Yeah, if you make a retroauricular incision instead of preauricular incision, the vascularity will be better and infection rate may be probably low.
We didn't try it. We never did it. The retroauricular, we use 10 millimeter anterior to the tragus, all the way, like I said, 10, 15, or 10.
Yeah, Dr.
We use the retroauricular incision, and at least at the moment, we just observe a better treating of the temporal muscle and less time for avoid the injury of the temporal artery. Maybe there is some more time to reach the base, but at same the base. But if you know, there is one paper that is better. Another paper 2 years later, they see is quite the same, but if you can do it. The second paper suggests this.
The other downline, when you do this from behind, it's very difficult to take the temporal squama because you need also to decompress above the temporal lobe. And if you do the incision per auricular and you go, so it's more easy, to take the bone there rather when you do this, then you have to crash over the ear. So that's another point to consider.
Another issue with retroauricular, which is probably not reported, is that if it is being done in a hurry or in the middle of the night, something like that, there is a risk of cartilaginous portion of the external artery canal getting injured. And I have seen patients with CSF leaking through the ear. So I think it's, I would still prefer preauricular incision. I won't prefer a retroauricular, and it's much easier to get to the base.
Thank you.
Yes, just a comment about the osseo reabsorption. That is 10% resorption of the bone. I think that sometimes we forget. No, just a comment. Okay, we forget to obtain the fusion between the bone flap and the skull, the osseointegration. This is a big topic for us. Put the bone flap close to the skull in order to obtain the bone fusion. Okay.
Other than that, what we also do in our practice is that we decorticate the bones.
Yeah.
Before we place it over the skull.
Yeah.
So that's again which helps, it seems. But then we do not have any literature to support it yet. Thank you, Dr. Eagle. And next, I will invite our dear friend from Sri Lanka, Dr. Surat. He will be talking on early tracheostomy in severe traumatic brain injury, effect on outcome and cause effectiveness.
Good afternoon, everyone. Thank you for the opportunity, distinguished chairpersons and the audience. This is my topic today: early tracheostomy in severe traumatic brain. So, I understand that ICU beds and mechanical ventilation is a global problem, even in the affluent societies. So, we all know that important factor which is responsible for the high mortality in patients with this severe brain trauma is hypoxia. So, endotracheal intubation is often necessary to maintain the airway patency and prevent the hypoxia. And it is often required because this patient's inability to protect the airway, and also the excessive secretions and inadequacy of spontaneous ventilation. So as we all know, tracheostomy has been a proven adjunct in the care of head injury patients worldwide. So a little bit of introduction, so I will skip this. So these are the indications, straightforward: weaning failure, absence of reflexes, impairment of respiratory drive, and difficulty in managing the secretions. But the beneficial effects, timing, and the indications is still debating, and it's subject to a considerable practice variation. So these are the advantages of tracheostomy or prolonged endotracheal intubation for your completion's sake. So suctioning of secretions are efficient, nursing care is efficient, greater comfort for the patient, sedation is less, dead space is smaller, and the lower airway resistance, and also complications of prolonged endotracheal intubation is not there. And also, more importantly for us, less incidence of ventilator-associated pneumonia and decreased periods of mechanical ventilation, plus the length of ICU and hospital stay considerably reduced. But keeping that in mind, the key is the appropriate selection of patients. So if you want to get the benefits, you should not perform unnecessary tracheostomies and identify the appropriate patients early at the time of admission. Controversy. So as we know, the timing of tracheostomy are still based on the expertise of the specialist rather than on the scientific evidence. And we routinely we agree that tracheostomy is done between within the first 7 days are called early, and now later than 7 days are called late. And also there's controversy regarding role of tracheostomy in severe head injury patients, because randomized controlled trials in general critical care, they have generally not found any benefit from early tracheostomy. But we know these results cannot be generalized to traumatic brain injury patients, because these patients typically require tracheostomy for airway protection, for depressed airway reflexes rather than the respiratory failure. So these are the factors we consider whether to perform and when to perform the tracheostomy. So I'm not going into details. Local medical practices, ethical and legal complications, and also the cost, apart from the severity of neurological injury and the evolution of trauma. These are the complications. There are early complications and late complications, which I am not going into the details, but a few words about tracheal stenosis. Most of the time we don't see tracheal stenosis because of the usage of high volume, low pressure cuffs these days. Right. So this is where we stand today. So this is my experience. So you can see, I'm working in the Sabaragamu province. So you can see in the second, the picture. This is the Sabaragamu province, which caters a population of around 3.5 to 4 million. And I'm the only neurosurgeon, and I have been the solo neurosurgeon for the last 5 years there. So we do have 70 consultants, but only 15 ICU beds. And you can see these critical patients are managed in high dependence units most of the time in the ward, often with inadequately trained nursing staff and equipments. So the objective in our study, this study is still in progress. So I have not given a conclusion at the end because it's a study which is still under progress. So our primary outcome is to look for the ventilator-associated pneumonia incidence between the early tracheostomy and late tracheostomy groups. And also the secondary outcomes as the duration of ventilation, length of ICU stay, and the hospital stay. Again, similar to the other studies, we have defined early tracheostomy as tracheostomy done within 7 days of intubation or literally admission. We haven't considered mortality in this study because we believe that mortality in ICU is a complex outcome that considers different variables, including age, sex, comorbidities, etc., etc. So mortality might not be driven by a single parameter like timing of tracheostomy. So we have not included that in our study. We have considered the ventilator-associated pneumonia as the main objective because it's one of the major complications which adversely affect the outcome. And as we know, there's 10% increase per day in getting pneumonia of mechanical ventilation. So this was a retrospective analysis in 2 peripheral units over the last 5 years. So we included 423 patients who presented with severe traumatic brain injury and had undergone tracheostomy from 2019 January to December 2023. So we have operated on 788 patients with severe traumatic brain injury during that time, and out of 445 undergone tracheostomy. So 56.5%. So very high risk, very high rate of tracheostomy. 22 excluded because they had other injuries like maxillofacial injuries, which influenced the decision for tracheostomy. And we identified 4 subgroups here. Right? So I will show you. This is what happened. So you can see on the right the statistics. Early tracheostomy within 7 days, 370, and late 53. So a big discrepancy. Why is that? Because we had a low threshold to do tracheostomy because of the resources, because of the restrained resources of ICU beds and ventilator beds. So within that early group, we have identified 3 subgroups. You can see ultra early, 67, within 24 hours. That means patients presenting with low GCS of less than or equal to or less than 5. So with corresponding radiological findings, and we know that this patient is not going to recover. So as the attending neurosurgeon, I decided to do the tracheostomy at the same go. At the same time, after decompressive craniectomy or cystostomy, we perform both. Early tracheostomy within 24 to 96 hours. That is typically after 48 hours of ventilation, we do the CT, and then we decide whether we can go for extubation or whether this patient needs tracheostomy. So typically on day 3 or 4, there is another set of patients that needs tracheostomy. So you can see the highest number is 196. Then relatively early, 4 to 7 days, that is after 5 days, the anesthetist decide whether this patient needs tracheostomy or not. So typically on day 6, another set of patients, 107. And then late, more than 7 days, it's very less, 53. So these are the results so far. Statistically significant difference in ventilator-associated pneumonia, length of hospital stay, ICU stay, and duration of mechanical ventilation noted between early tracheostomy and late tracheostomy groups, obviously. Within the early tracheostomy groups, I showed you those subgroups. There is a significant difference in pneumonia between ultra-early group and the relatively early group, but no difference in other parameters among the subgroups noted. So you can see this is the ventilator-associated pneumonia incidence. You can see the overall incidence is 24.3, which is relatively less compared to the other regions with the this type of resources. Ultra-early 10.4, and late you can see 43.4%. So number of deaths due to ventilator-associated pneumonia anyway is less, 5.7%. So altogether, ventilator-associated pneumonia in early tracheostomy group 21.6 versus 43.4 for late tracheostomy groups. So these were the complications we observed, and you can see the tracheostomy was done by neurosurgeons 295 cases, and ENT surgeon only 120. This is only open tracheostomy. We don't do percutaneous tracheostomy. Literature review, I'm not going into detail. So similar results were found with these studies as well. So this is just to show you one slide from one of the previous studies. This study was done for acute subdural hematoma by myself, evacuation only. So we had a set of patients that we did the evacuation only for acute subdural hematoma, plus another set evacuation plus the cystostomy. So I observed that there's a significant difference in number of tracheostomies in the cohort where we did the cystostomy as an adjuvant. 16.7 versus 35.1, which is which was statistically significant. So you can see, this is the slide from that presentation. So there was a remarkable reduction in the cranioplasty as well as the tracheostomies. Just to show you an example, this was the inspiration for me to perform cystostomy. This young girl, 18 years, preoperative GCS 3. So I did the cystostomy, and I did not put the bone flap back. And at the same time, you can see we did the tracheostomy, and we put the bone flap in the abdomen because our refrigerator facilities were not very good. But I did not expect that patient to recover that quickly. On day 25, we put the bone flap back. We did the cranioplasty, and patient was discharged on day 27. And that was the inspiration for me to do the cranioplasty and also consider tracheostomy at an early age at the time of surgery. Some would say it could be an overkill, but for me it has paid off very well. So another case you can see it's very bad CT GCS3, but we did the, this is cystonostomy and this is post-op day 15. So several cases, more than 10 cases like this, very pretty bad cases, but had a very good outcome. So I have not given a conclusion because this is still a study in progress. So we'll give you the results in the near future. Thank you very much.
Are you doing mostly the surgical tracheostomy or PCTs?
Surgical, only surgical tracheostomy.
Oh, no PCT.
We don't do repetitive response.
Thank you, Dr. Surat. Next, we will invite Dr. Brett Hockey from Australia. He will be speaking on anesthesia and neurotrauma in an Australian trauma center. Dr. Brett.
Thank you to the chairs and to the committee for inviting me. So a special mention for Prof. Kate Drummond, who has provided me with more neurosurgical cases than any anaesthetist should really have to ever endure. I come from the Royal Melbourne Hospital. We're one of 2 level 1 trauma centres in Victoria, Australia. We serve a population of just under 7 million people for those 2 level 1 trauma centres, which I appreciate for most people here may not seem like that many, but for us represents about 25% of the Australian population. We also have the busiest neurosurgical centre in Victoria. It's a fancy view of a trauma helicopter landing on the roof of the Royal Melbourne Hospital, which seems like we have lots of resources, but in fact the building was largely built in the 1950s out of brick. The mortar is degenerated and the bricks are falling out, so we have chicken wire on the outside of all of our buildings to stop the bricks from causing their own neurotrauma. So trauma in general is a team sport, and I like this saying. We have a trauma centre, we have trauma systems in place, and they've been shown to reduce morbidity and mortality associated with trauma by 15 to 30%, and they represent probably, after primary prevention strategies, the greatest advance in improving trauma outcomes in the modern era. But teamwork with proper leadership, especially from the neurosurgeons when it comes to neurotrauma, is critical. The principles, probably more than half of the speakers have had some sort of statement like this on one of their slides, which is to ameliorate secondary injury. And in basic trauma, that's by restoring adequate perfusion and achieving hemostasis, either surgically or by correcting any coagulopathy that the patient presents with or develops. And there is no homeostasis in a patient until you have adequate hemostasis. From ATLS trauma principles, catastrophic hemorrhage, airway, breathing and circulation all come before neurological disability. And I'm not sure I've met any neurosurgeon who likes to be 5th on any list, but there they are. So I'm a simple person, and this seems trite to say that neurosurgery for trauma is simple, but from my perspective, in traumatic brain injury, the options for a surgeon are to remove bone, to remove brain, to remove blood, including CSF, and to facilitate ICP monitoring. And for spinal cord injury, it's to reduce dislocations and to stabilise unstable fractures. And that may seem a bit unfair to the neurosurgeons, but I can be even less fair to the anaesthetists, because anaesthesia for neurotrauma is even more simple. We just need to manage the airway, and we need to stop the patient from moving. The neurophysiological management, everyone's discussed, and we all know that that's extremely complicated. It's complex, there are competing priorities in multi-trauma, especially when the patient is bleeding. It is continuous and requires meticulous attention to detail, as is evidenced by even a single episode of hypotension in brain-injured patients. And it's multidisciplinary and requires communication, and often that can be very difficult. The roles of anaesthesia are pretty straightforward: resuscitation and stabilisation, which we do in the emergency department and carry on in theatre. We manage the airway and protect it, and we provide anaesthesia for imaging, craniotomies, spinal fixation, and for any other associated traumatic injuries for the patient. We are crucial in intra-hospital and inter-hospital transfers, and we provide perioperative analgesia management, and many of us have a longer role in ICU management of these patients. The goals of anaesthesia harken back to my slide 5 slides ago, which are to reduce secondary injury. And we do that by restoring adequate perfusion primarily to the brain, maintaining cerebral perfusion pressure using fluids and drugs, and correcting any oxygen demand mismatch, which is to give oxygen to decrease cerebral metabolic oxygen requirements, usually with medications that are neuroprotective, anaesthetic agents, and by administering blood to improve oxygen carrying capacity. We facilitate hemostasis. We're the primary people in theatre who monitor and correct coagulopathy and try to avoid or mitigate that lethal triad. We like to be able to facilitate timely cerebral decompression and spinal stabilisation. So getting the patient to theatre for definitive surgery is a priority for us. You'll also note that one of the primary roles of anaesthesia is to provide amnesia and analgesia, but that falls fifth on our list of priorities in this circumstance. But also it's really important that we facilitate early post-operative neurological evaluation for the surgeons. The specifics of anaesthesia are easy. We manage the airway and we intubate the patients. We stop the patient moving and we use drugs to do that. And I'll go through those in a little bit more detail. Transfusion and coagulopathy I'll leave aside. Intubation and traumatic brain injury has a very simple priority, and that is to maintain adequate cerebral perfusion pressure during that process and avoid rapid changes in the cerebral perfusion pressure. And to control the carbon dioxide, as we've heard before, the importance of hypercapnia, and to maintain oxygenation. In spinal cord injury, there's a lot more evidence, no, not a lot more evidence, a lot more research and a lot more controversy, but no technique in specific in terms of managing the airway has been shown to be superior to any other in patients with unstable cervical spine injuries. No neurological advantage has been shown by using awake techniques to secure the airway over asleep techniques. All airway manoeuvres that we perform as anaesthetists are associated with some degree of cervical spine movement, even fibre optic intubation. And manual inline stabilisation, which is the standard of care, makes that job more hard. It increases the time to intubate patients and increases the incidence of failed intubation. The only good thing that's happened in the last 20 years is the advent of video laryngoscopy, which increases the rate of successful intubation. But in the end, it is the expertise of the clinician which is probably the single biggest factor in determining success in intubation in spinal cord injury patients. The drugs that we use have been discussed before. Ketamine has enjoyed a resurgence. It is commonly used in most Australian emergency departments for intubating trauma patients. Propofol is mostly the realm and the preference of anaesthetists for intubating all patients, reduces intracranial pressure, is neuroprotective, but it is also cardiovascularly compromising and reduces mean arterial pressure, particularly in induction doses. Etomidate is around and it is used in New Zealand but not in Australia. Benzodiazepines are commonly used in small doses at the start for induction to reduce the doses of propofol required to ameliorate the blood pressure consequences. And it doesn't really matter which of the muscle relaxants you choose to use. There's lots of discussion about succinylmethonium and its effects on ICP and the slower onset of rocuronium, but there's been no difference shown in terms of outcome. To keep patients asleep, there's a lot of discussion about whether propofol should be used and whether volatile agents preserve cerebral autoregulation less well or more well than propofol. But as we saw before, autoregulation can be abolished with even minor traumatic brain injury, so it probably is not relevant in traumatic brain injured patients. Propofol is easy to use for transporting patients around the hospital, but it's harder on the blood pressure. Volatile agents require scavenging, and if you're going to move the patient, you need to switch them to an intravenous agent anyway. Dexmedetomidine has been studied in rabbits, not so much in humans. Reduces ICP at low doses, maintains ICP, but increases MAP at higher doses, and it's not intrinsically amnestic. Ketamine we don't use for maintenance in Australia, but it is commonly used in low and middle income countries, especially in Malawi. I've noticed they use it in their intensive care.
I'm also anesthesiologist.
Yes.
Are you using Kiva so often or not Kiva?
Sorry, are we using?
Total intravenous.
Yes, I completely use totally intravenous
For
anesthesia.
that you are using propofol as well as the muscle relaxant or the fentanyl or what?
I use propofol and I use dexmedetomidine to reduce the propofol that I need, and I use boluses of rocuronium when needed.
Okay. And what are the monitorings you are using?
Monitoring. We don't have particularly sophisticated monitoring. We have BIS and EMG, but BIS has not been shown to or tested or clinically proven in traumatic brain injured patients.
Okay.
So I'm not aware that it's particularly useful. So it's not routinely used in anesthesia for traumatic brain injury, nor in
And I wonder what
Dr.
is
Yugal,
your-
please use mic. Yeah. The mic.
I'm sorry. I'm talking about laryngeal mask, okay, especially in awake craniotomy. We tend to use it quite a lot. Do you feel comfortable with that? What is your opinion about laryngeal mask?
Laryngeal masks are easy to insert, save lots of lives, but I don't think they have a particular role in the trauma patient. If you're going to paralyze the patient to control their carbon dioxide, which is important in traumatic brain injury, you don't have a secure airway with a laryngeal mask airway. And so,
No, in awake craniotomy.
So I don't use them in awake, so either I keep the patient awake.
Okay, so that's why we don't put it. Okay, all right, thank you.
That's true. Next, we will invite Dr. Dhaval Shukla from Bangalore NIMHAMS. He will be speaking on management of traumatic brain injury without ICP monitoring.
Hello, good midday to everyone. So I'm going to talk, when I told the chairperson that I'm going to talk about the topic, he told everybody will beat me. So how many of would you like to beat me that if I talk on that managing head injury without ICP monitoring? Please raise your hand. Who would like to beat me? Oh, so one wants to beat me and one wants to... Who is supporting me? Raise your hand. Oh, great. So I have got more supporter, Amit. I proved you wrong. Okay. Without ICP. Okay. Yeah. Okay. So, so my talk is over. I can go home. That's so why I chose this topic? Like first talk during this session was on auto-regulation. Not only ICP monitoring, at higher level of ICP monitoring. So Brain Trauma Foundation guidelines, if you see evolution of these guidelines from 1996 onwards, there are no standards on ICP monitoring. There are level 1, level 2, and level 3 should be monitored. It's not like definitely better. But what happened in latest guideline, they did not use the word should be, must be. They just, it reduces mortality. You want, you monitor, you don't want, you don't monitor. In spite of this Brain Trauma Foundation guideline, all the supporters of ICP monitoring strongly recommend ICP monitoring in severe TBI patients. And what is the rationale? Early identification and treatment can maintain adequate cerebral blood flow and oxygenation. However, such strong recommendations are not based on level 1 evidence, and these are derived from retrospective and limited prospective observational studies by the people who do ICP monitoring, not by the people who do not do the ICP monitoring. So there was only one randomized control trial which was performed in developing country, because the people who do ICP monitoring, they did not want to try whether it is useful or not, and it did not show benefit of ICP monitoring over conventional clinical and imaging monitoring. So the investigators of these trials were quite upset with the results, and they feared that the world will stop monitoring ICP, and what will happen to us? We are the proponent of ICP monitoring. So they released a consensus-based interpretation of best trick. So they want us to interpret the trial. So they feel it is a study protocol, not ICP monitoring per se protocol, and it applies to only to those protocol and specific study groups and should not be generalized. That means should not be generalized to America and Europe, and strongly calls for further research on ICP interpretation and use, should be applied cautiously to the regions with much different treatment milieu, did not investigate the utility of treating monitored ICP in the specific group with established ICH, and should not change the practice. Most important, their statement, it should not change the practice. So what happened after this trial? People who were monitoring ICP continued to monitor ICP. They did not stop monitoring, and people who were not monitoring ICP, they were not motivated to monitor ICP. So this was from developed country. Now there is one more much developed country, Japan, and I think Sarah is here, who gave a talk on D-dimer. So this is his paper on Japanese trauma data bank. So they also used to do ICP monitoring a lot. It was 55% and it reduced to 28% over time. And what they found that the ICP monitoring definitely reduced mortality, but there was no change in the outcomes of unfavorable outcome. Whereas ICP monitoring was associated with more intensive therapies. Actually, there was a talk by Florian, which we missed, too intensive care in traumatic brain injury. So ICP monitoring leads to too much intensive care in traumatic brain injury, just because you chase a number. So what happened in America, we hear only the neurosurgeons because we go to only neurosurgical conferences, and we are the people who like appreciate them, they appreciate us, and that's how things go on. But American College of Surgeons, who does not comprise of neurosurgeons, they evaluated trauma quality improvement program, and you will surprised to know that they were neutral people, and they found that when indicated according to BTF guidelines, only 10-11% patients underwent ICP monitoring even in America. And they found that ICP monitoring was done in more severe and serious cases. That's why ICP monitoring actually resulted in more mortality, which is like counterintuitive. That is not truth, but it was monitored in more serious patients. So this is the more recent study called Synapse ICU study. 3 centers from India also participated. It was a global study, and they found practice of ICP monitoring, how it influences the outcome. So you can see there is a lot of heterogeneity of ICP monitoring. So the probability a person will undergo ICP monitoring when indicated varies largely. Even in America also, you can see green dots and orange dots over. So not entire America does ICP monitoring based on BTF guideline. Not even entire Europe does, and India definitely not many people do. And in Australia also, you can see one green dot and one orange dot. That means there is a center which does ICP monitoring, there is a center which does not do ICP monitoring. So there is a lot of variability in ICP monitoring practices throughout the world. So they published this. The 6-month mortality was lower in patients who had ICP monitoring than those who were not monitored. Now, if you see, this is only mortality figures. But when you read in between the lines, there was no difference in the unfavorable outcome in patients who underwent ICP monitoring and did not undergo ICP monitoring. So what you do when you monitor ICP, your only goal when you are doing monitoring of ICP is to send back patient out of ICU alive. That is their only goal when you do monitoring, and that's the goal which you achieve. But when they did subgroup analysis of low middle income countries, there was no difference in 6-month mortality in patients who underwent ICP monitoring as compared to the patient who did not undergo ICP monitoring. So why there is so much heterogeneity in the results? So ICP monitoring is only one figure. You have to do a lot of other monitoring, other treatment, and there is something in low middle income countries, out of sight, out of mind. Once you discharge from ICU, don't bother about the patient. And it is not correct to compare the outcomes at 6 months between developing and developed nations, because there is a lot of aftercare in developed countries, social support, nursing support, frequent follow-ups, rehabilitation, which are lacking. So you will not be able to extrapolate what happens there with what happens here. So what happens at NIMHANS? Ours is like National Institute of Mental Health and Neurosciences. We are proud to say it is an institute of national importance. We get a lot of funding, and you name a thing which is that is available in NIMHANS, whether it is gamma knife radiosurgery, intraoperative MR, everything is available. So this is one picture in our ICU. The patient is not only going to undergo ICP monitoring, is undergoing TCD monitoring, cardiac output monitoring, and so many monitoring. But is it true? Yes, it happens at NIMHANS, but only under research protocol for some students' thesis or when there is a research fellow available to do all these things. But if I ask my resident to do all these things besides doing some 10 craniotomies per day for head injuries, he will not do. So only when the research fellow is available, a study is going on, all this monitoring will be done by. This is the real case scenario. In our these two pictures are from the same hospital. First picture from the third floor in intensive care unit, and second picture from the ground floor in the triage area. So we receive so many patients. So it is just pick and choose that which patient will undergo ICP monitoring. It's not a practice. So we published 3 studies, and proudly we published first study in 2007, that intensive care management of head injuries without ICP monitoring. No one will dare to publish such a study. And then second time period was in 2011. We developed a prognostic model for mortality in intensive care unit patients. And third study in 2018, we used disability rating scale at the time of discharge. This was the first proper study where we followed a patient for 6 months. Every month we used to call the patient and ensure we kept in touch with the patient, and then assessed outcome 6 months later as well. So what we found in 2006 study, the in-hospital mortality was 31%, which was very, very high. And in 2008, we had separate emergency and trauma building with more number of ICU beds. We increased the number of MCH neurosurgery residents. We started neuroanesthesiology and neurocritical care 3 years program, so we had more residents. So after that, the in-hospital mortality came down to 15.3%, and in third period, it remained at 16%, which was more or less same. So we are not reducing further. So in first study also, Glasgow Coma Scale, hypotension systems status. Second study also, same predictors were there for the outcome. And in third study, only Glasgow Coma Scale was the only main predictor of outcome. So it's not the monitored values, some figures, a number 20, 22, 40, 60, 70 CPP, which determines the basic clinical features to determine outcome. And in the third study, we did 6-month outcome. 6-month mortality was 31%, which is at par with most of the developed nation. The mortality is nearly 1/3 for all severe TBI patients managed in intensive care unit. So the question, can TBI be managed without ICP monitoring? Yes. So this is a paper from paper on non-invasive ICP monitoring. So there are a number of clinical and imaging indicators which indicates that ICP may be high, and that's what we practice on, and we have been practicing pretty well. So main is midline shift, basal cistern compression, and GCS and pupillary reaction. And the same people who did best trip trial, they knew that ICP monitoring is going to go away. So they made one more protocol called Crevice protocol, that how to manage TBI without ICP monitoring when ICP monitoring is not employed. So this is the protocol. This is not for you to read right now here. It is freely available in Journal of Neurotrauma. So ICP, TBI can be managed without ICP monitoring, except for blood pressure, pulse rate, oxygenation, and respiration. Rest all are of questionable values in ICP monitoring. In management of traumatic brain injury. Say it is ICP, PTBO2, microdialysis, or whatever things you have. So if you can do this 5 commandment, head and elevation, treat hypotension, treat hypoxia, treat fever, and maintain normal glucose, we can achieve as good as result as with many multimodal monitoring. Thank you very much.
Yeah, Dr. Kate.
Can I understand? I think that one of the things that we don't consider with ICP monitoring that I've been thinking about a lot is we think about the advantages, but not about the disadvantages and complications. And 2 things come to mind, which is drain infections, of course, which you use them for ICP monitoring the external ventricular drain, and the patient gets ventriculitis, which is a disaster. But secondly, sometimes in our ICU, we get in a cycle where the patient will cough, the ICP will go up a bit in the middle of the night, suddenly they're resedated by the intensivists, you come in the next morning, you can't neurologically assess them, so we turn off the sedation, the patient coughs, they're suddenly, I'm senior enough that I just say, pull out the monitor, stop, turn off the sedation. But the junior people, sometimes I've seen patients, this terrible cycle of responding to an ICP that's spurious for a week or 2, and that's very dangerous for the patient, and it's very difficult to stop.
Yeah. Yes, Shiga.
Mike. Thanks, Kate. 2 points you mentioned. One is the ICP monitor insertion may have complication, and the other is how to manage when the patient is coughing and sedation stuff. Well, we are doing in all our patient ICP monitor, all our patients that are in coma, we put ICP monitor. And like in any other thing, we have a strict protocol how to do it. Usually the residents puts the ventriculostomy under navigation, so it's always on the place with antibiotics. And so the rate of complication when your staff is trained is relatively low, and also the issue of coughing and sedation is also something that we need to train and to explain to the nurses and to the resident. We can deal with that. So it's not, if this is part of the routine of the ICP, of the ICU or no ICU unit, and people knows how to deal with that, how to clean, how to dress, when to change the bag and everything. We forget that in some of the ICP that at least most of them, it's EVD, actually we drain CSF. So it's also for treatment, it's not also for measurement. So I think it's the routine of the ICU, the philosophy, the energy that people want to put in it. By the end of the day, at least in our point, ICP is necessary to evaluate the patient. CT, neurological examination, glucose and all the stuff is not enough. But I agree that there is no class 1 evidence for that, and hopefully there will be in the future.
Okay.
There was this.
I think just very brief.
Yeah, nothing important.
So,
thank you.
Thank you. Just a comment. I want to do a comment just to say that we are neurosurgeon and we are used to treat intracranial hypertension. This is a problem of how to measure the intracranial hypertension. Not ICP monitoring, it's how to measure. We can measure intracranial hypertension with the CT scan, brain swelling. We can measure with the monitor. So maybe that it is a problem of threshold.
Correct.
Okay.
So I could. Okay, thank you.
Dr. Tapa, he talked about the robotic placement of DVA catheter in slide-like ventricle.
May I have my slides, please? Well, in my center, we are using ICP, very useful procedure, because what we have found is ICP actually helps us to give a figure, and that can even be interpreted by a non-neurosurgical friends. But before they sedate the patient, they always ask us as to what should the plan be, so we have complete control. Now, what I have been asked to present was basically a video presentation on how I do it, but then this session seems to be a much more of a discussion type, so I have a little bit changed my presentation. This is not a presentation where I'm professing the use of robotic method to place an EVD in a thin ventricle, but I'm just trying to showcase how a robot can also be used. It's an extended uses of a robot. So what our center is having a cranial robot. So this is not a commercial presentation. I have nothing to do with that. My travel is not sponsored by the companies. Well, we all know that the slit-like ventricles are less than 3 millimeters in size. So that's why they're very difficult to cannulate. However, we all know that EVD placement inside the ventricle is the standard, because it can not only help you to measure the ICP correctly, but also helps you drain and therefore control the ICP much better. Now, this has already been shown that EVD is a gold standard for measuring ICP in various literature, and we all know that even draining of 1 ml of CSF can actually make a lot of difference in the value of the ICP in raised platform or raised on the right side of the curve. Now, what we are using most often is basically a freehand technique of putting an EVD, which is fairly good for a normal size ventricle or a dilated ventricle. However, in the thin ventricles, it may be used by an hysterotic frame, frameless hysterotaxy. Now, literature is there where they have supported using of image guided system. Dr. Yigel was also mentioning about it. What they have found, they have made two groups. What they have found that if they are doing a freehand placement of EVD in these types of ventricles, small ventricles, the accuracy rate is around 43.2%. By using an image guidance, it can be gone up to 75%. That means still there's a 25% of the patients where your placement of the EVD may not be accurate. And in that case, we are using a robot. And how the robot is helpful is that it gives you a precise location. It gives you a real-time guidance as to your precision. It gives you a feedback. And of course, it is a robotic movement, so you can trust on it. And more than that, what we have found is that by tracing the pathway through which the EVD is going through the brain, you can actually save the vessels over the cortices level. We can actually minimize the cortical pathway. We can do cross checks, and of course, the exact length of the EVD can be measured before you place it inside the cranium. So this is the advantages which you are finding with the robot. So this one publication I found while I was preparing the talk from All Indian Institute of Medical Sciences, New Delhi. They have a ROSA robot where they have used this to put a shunt inside a slit-like ventricle. In our case, we are using it routinely in the patients with a third ventricle, particularly in the neurotrauma situation. So this is the list of steps which I will be dealing with. So the most important thing is to identify the cases where we are placing these EVDs. So our criteria is GCS of between 8 to 13. Anything GCS of less than 8 goes for a straight away decompensated cranectomy. We do not place an ICP in those patients. But from 8 to 13 patients with clinical deterioration, where we are trying to see that patient may be served with some other methods of controlling ICP, then we do place an ICP catheter. So like in this case, this was a case of an evolving MCA territory infarction, where we found that the patient GCS was around GCS of 12. So that's why we tried to do an ICP monitoring in this patient and then control the ICP by draining the CSF. Now, the point of insertion is usually the standard burr site for any EVD, that is 3 centimeter from the midline and approximately 1 centimeter anterior to the coronal suture. So we mark it. So this is the case of an acute subdural, as you can see on the left side. So we have marked the site of insertion on the right side, and then we always retrace the pathway of our EVD tips so that we can actually avoid the sulcus in our pathways as much as possible, and also any vertical vessels if there are any. Now, the registration process is very, very important because we want to minimize the error to less than 1.5 millimeter at the most, because if your registration is errogenous, then of course your placement may not be accurate. So there's a routine sets of robotic instrument set which comes with every cranial robot. So this is from the Medtronic system. Now this is how it is set up after painting and draping the patient on an OT table. So we place the robot very nearby, and then we put the tracker on the robotic head. So after this thing, we actually register the robot to the system. So this has already been done. So you can see there are 3 lights which actually blows up. So one light is the home button. The second one is the proximity button. That means at a certain level, when you come near to the brain, which you have registered on the patient, then this button will go blue, and then the system sets itself to its own trajectory. So you can see the blinking is actually alternating, and now it's ready position. So once the blue button comes on the rightest of the panel, then that means that a trajectory has been defined. So we can now move to the next step, that is making the burr hole. So it is very similar to like putting an SCCEG electrodes. So we define the depth of the drill hole depth by measuring it on the CT scan, and then so this is how it looks like. So the robot has 2 arms through which that particular tube is placed, and the EVD is pushed through. And then this is while we're making the burr hole. So this is the burr hole through the robot. So the chances of error is very, very lesser. The EVD will not go to any other place. You have made a trajectory through a tube. Now, when you are placing an EVD, you have to have a special catheter, because the normal catheter by surgery where it has around 3.5 centimeter. So it will not go into a 3 millimeter with the ventricle. So we use another special one from the surgery company, that is 2.5 millimeter. And we also have some Chinese supply, which is like CerebroFlow, which comes in 3.3 millimeter diameter. Now we mark the depth which we have measured on our system, and then we go for placement of the EVD. So the placement is always done after we have seen that the target alignment error is 0. So as you can see, there are 2 situations, 1 or 0.2 millimeter error which is being displayed on the system. So that is not acceptable to us. We will only go when the target alignment error is 0. Now this can happen because of slight movement on the robotic arm because of your instrumentation. So whenever this alignment error is red, or in case not 0, then we do not go in, particularly in the small ventricles. And then this is how we mark it, the depth on the EVD. And then this is the procedure of putting the EVD through the EVD tube inside the brain. So once I'm gone inside, see, this is a give-way filling once we hit the ventricle, and then we can just take the stylet which is placed inside out. And you can see in a moment that as I will remove the stylet, there will be gush of CSF which comes out. So that's how this is the EVD is placed, and then my assistant will hold the EVD tip to the skin so that it does not move out. Then we'll tunnel it through the skin. And then we use a special fixation device so that the EVD tip is not moved. And this is how the post-operative images looks like, a perfect placement in the ventricle, and this can be used not only to monitor the ICP but also to drain the CSF to control the intracranial pressure. Of course, this is not a very cheap equipment. It comes in crores, and that's why the initial cost of investment is high. As I said earlier, this machine we bought it for the placement of SEEG electrodes, but then we have found an additional use of the cranial robot in our place. And because of this, I now is having a good sleep in the night because my residents can also use robot, and this have actually made the precise or accurate local placement of EVD successful in our place. And there is definitely additional time of required for the stealth registration, but then this actually decreases as the proficiency of registration increases. There are certain risk and apprehension when we started this project earlier. That was like risk of plunging when we can go inside, but then of course by maneuvering our hand movements we can control that. Chances of infection is very, very less because we are painting and dripping the hair, the side. And then the chances of optical blind out, if in case somebody is standing between the optical pathway, which is optical sensor, which is looking at your machines, and then object registration delays can occur, and some amount of navigation errors are expected if in case we have not followed the steps thoroughly. So this is very, very important to follow these steps at each point of level and to correct it there and then. So to conclude, we found that the neurosurgical navigation system, though it increases surgical accuracy, by having an intraoperative tracking system in the form of a robot, we can actually have a lot more safer, faster, and a far less invasive method of putting an external ventricular catheter inside a slit-like ventricles. Thank you.
Yes.
I would like to know which channel work do you use? Because the system
So this is a Medtronic called Auto Guide.
the system has two channel work from 2.2 and another. Do you use the tubes?
Yes, the reducing tubes.
Or the channel work of the tree?
So we use the reducing tubes which comes with the robot itself, and that allows our tube to go inside it. It actually fits very well. The reducing tubes. Yes. No, that comes in the standard set. Yes, in the standard tube.
The left, the 2.2 millimeter, because your catheter is 3.5.
Yes.
Okay, another question from the back.
Enter the needle, the brain is spouting out. What is the success rate of hitting the ventricle for you?
Well, in my series, we have done. I think the last week we were doing an audit. We have already crossed 76, and we have been able to put the EVDs in almost 100% patients.
100%.
Yes, but then there are three caveats which I like to enumerate. One is that we always follow the CT scan, which is taken just before the procedure. That's number one. Because we want to rule out that there is no such surgical indication to operate the patient, so rather than going for a monitoring like an ICP. Number two is our registrations are absolutely meticulous. We do not want to have any surgical registration errors, because here we are talking on millimeter accuracy. So that's why we have to be very much accurate. And third is that in our patients, we have actually done all these procedures under GA. So there is no element of patient moving anywhere. So this is a completely a GA procedure. So we explain the patient family that even though our indication to put a patient under general anesthesia is GCS of less than 8, But then to make this procedure much more precise and to control the patient's ETCO2s and all other things for ICP monitoring, it will be better to put the patient at the GA.
Okay.
How
we
efficient
should-
is the drainage? Considering their slit ventricles, do you really get, or do you have to abandon it many times?
Well, you have seen in the video itself, the CSF does come. So what we are looking at, the thinned out ventricle does have still around 10 to 15 mils of CSF in them. So draining that particular CSF from the lateral ventricle is good enough to decrease the ICP to a factor of 5 to 10 millimeter mercury. And mind you, that particular on the right, when we are in the right side of the curve, even a draining of 1 millimeter CSF is good enough to control ICP in a large number of patients.
Okay.
However, in our series of 76 patients in the last audit, we have to undertake decompressive connectomy in almost 65% patients. So
Okay.
only 35% could be managed just by CSF drainage. The rest, all other patients had actually gone for a DC.
We should keep going.
Yeah, thank you.
I want to say that I was wondered that you did not use the. No, okay, you can. You did not use the ultrasound. Okay. So.
Focus. Yes. This is not Arpita. May I invite Dr. Arpita Jindal, neuropathology of chronic traumatic. Hello.
Good afternoon, everyone. Today I'm going to speak on the neuropathology of chronic traumatic encephalopathy, termed as CTE. And to start this, I was first started with an anecdote, and I would like to tell you that how this it started. While conducting an autopsy on the former national football player Mike Webster, a forensic pathologist, Umalu, he discovered neurological deterioration that was similar to Alzheimer's. So Umalu named this disorder as chronic traumatic encephalopathy, and all the findings were published in the journal called in our journal Neurosurgery in 2005, almost 2 decades back. And since then, other athletes also face the same diagnosis. More and more research is being done on this, and even Hollywood went into making a movie on this called Concussion, and I'm sure you all would like to watch this movie also. So coming to chronic traumatic encephalopathy, it's a progressive tauopathy, occurs as a consequence of repetitive mild traumatic brain injury. Most instances of CTE occur in association with play of sports, also being reported with blast injuries and neurotrauma. The symptoms are cognitive impairment, dementia, memory loss, behavioral and mood changes, and diagnosis with certainty is only by neuropathological examination of brain tissue. The spectrum of pathology ranges in severity from focal perivascular epicenters of neurofibrillary tangles in the frontal neocortex to severe tauopathy affecting widespread brain regions. Given the importance of sports participation and physical exercise, it is critical to identify the genetic factors as well as to understand how other variables contribute to the development of CTE like stress, age, and substance abuse and other exposures. Coming to gross pathology, it is unusual in early or mild CTE. We can have cavum septum pellucidum, mild enlargement of the ventricles, and prominent perivascular spaces in the white matter. In intermediate and advanced CTE, besides these, you can have gray and white matter atrophy, reduction in brain weight, septal fenestrations, atrophy of thalamus, hypothalamus, and mammary bodies, thinning of the isthmus of the septum corpus callosum, and depigmentation of these areas. Although grossly identifiable cerebellar abnormalities were described in the initial reports of CTE affecting the boxers, macroscopic abnormalities are rarely present in CTE associated with other sports or activities. Neuropathological features of advanced chronic traumato-encephalopathy. This is in a formal professional football player. Despite the relative large size of the brain, there is generalized symmetrical brain atrophy, flattening of the hypothalamic floor, atrophy of the mammillary bodies, and substantia nigra shows pallor. In an Alzheimer's, also shows generalized symmetric atrophy, but the hypothalamic floor, mammary bodies, and substantia nigra are normal. So these are very specific for CTE. Depigmentation of substantia nigra, and again locus ceruleus I would like to emphasize, degeneration of the frontopontine tracts in the cerebral peduncle. The coronal sections, they may show pronounced frontal and temporal atrophy, marked ventricular dilatation, cavum septum, and absence of the posterior septum. The floor of the hypothalamus, in this case, is severely thinned out, and the mammillary bodies are markedly atrophic. Multiple septal perforations may be present, and the posterior septum may be absent with only small blood vessels remaining. Coming to the microscopy, the criteria for neuropathological diagnosis of CTE, perivascular foci of p-tau immunoreactive astrocytic tangles and neurofibrillary tangles. Irregular cortical distribution of p-tau protein immunoreactive neurofibrillary tangles and astrocytic tangles with a predilection especially for the depth of the cerebral sulci. Clusters of subpile and periventricular astrocytic tangles may be seen in the different areas of the brain. Neurofibrillary tangles in the cerebral cortex located preferentially in the superficial layers. Perivascular p-tau pathology found in clusters at the depth of the cortical sulci distinguishes this from the tauopathies, including the Alzheimer's disease. Now, there are 4 pathological stages in cases of CTE. In stage 1, the brain is grossly unremarkable. Microscopically, there are only isolated perivascular focal epicenters of p-tau NFTs and neuropil neurites. Occasionally, p-tau immunoreactive glia and glia processes may be seen in stage, so that in this case, if you see these, you can see only a few couple of dots. These brown dots are the immunoreactive p-tau NFTs. There may also be sparse NFTs scattered throughout the adjacent cortex, subpile p-tau astrocytic tangles, NFT and neurites also found in locus ceruleus, and clusters of reactive microglia found in the white matter with axonal swelling and distorted profiles in the subcortical U fibers. In stage 2, the macroscopic changes are again subtle. However, microscopically, there are multiple epicenters. So as compared to the previous one, you will see that there are multiple epicenters of this brown colored immunoreactive p-tau protein seen in the depth of the cortices. Typically, they consist of same perivascular p-tau NFT tangles and neurites. It may be associated with p-tau astrocytic tangles in the overlying subpile region, same as stage 1. Mild TTP43 pathology may be found as abnormal neurites and neuronal inclusions, and clusters of reactive microglia are often found. In stage 3, now the macroscopic changes are more. There is reduction in brain weight, mild frontal and temporal atrophy, enlargement of these ventricles, septum abnormalities including cavum septum pellucidum, perforations and fenestrations. Pallor of the locus, these are the same which you had seen earlier also, except atrophy of mammillary body, thalamus and hypothalamus, and thinning of the corpus callosum. Microscopically, confluent patches. Now you see more and more confluent patches of NFT, NTs, and astrocytic tangles around the blood vessels at the sulcal depth, and NFTs are found in cortices, and besides that, you also find them in different areas like olfactory bulb, hippocampus, cortex, amygdala, hypothalamus, mammillary body, and all those I have described. Neurofibrillary degeneration occurs in the hippocampus. Microscopically, the pathology now becomes widespread. Also in stage 3 CTE, the amygdala, hippocampus, and entorhinal cortex shows substantial neurofibrillary pathology that is found in the earlier stages. So you can see the brown color keeps on increasing, as you can see in this one also here, and other also small dots which you can see. Macroscopically, in stage 4, substantial decrease in brain weight, generalized atrophy, severe thinning of hypothalamic floor, atrophy of mammillary bodies, septal abnormalities, and other things. This is the stage 4 thing. Then widespread, microscopically, there is widespread myelin loss, astrocytosis of white matter, neuronal loss in the cerebral cortex, hippocampus, and substantia nigra, and the last one. Now, what is the relation of tau pathology to trauma? The pathophysiological mechanisms, they still have to be identified. They are critical to developing latent and progressive neurodegeneration and tauopathy. When a semi-solid brain suspended in the CSF inside a bony skull, it is subjected to rapid acceleration, deacceleration, and rotatory forces associated with the impact injury. The brain elongates and deforms, stretching the microstructural elements including neurons, glial cells, and blood vessels. These stretch forces predominantly affect the long fibers, specifically axons and blood vessels, and are more severe where the direction of axons change or where there is a change in tissue density. The early or predominant involvement of the superior dorsolateral frontal lobes in CTE, affecting formal footballers, parallels the high frequency of impact they had it on the top of the head compared to those in the front, side, and back of head. Likely, additional factors that play a role in the initiation of p-tau pathology should also be studied. Studies have suggested that children and adolescents experience prolonged recovery rates. Animal models have shown that stress can lead to tau phosphorylation. Environmental factors, alcohols, opiates, performance-enhancing drugs will also play a role in tau aggregation. P-tau immunoreactivity in opiate users has been shown to be significantly higher. Glucocorticosteroids have also been associated. So these tau phosphorylation and misfoldings are potentially reversible processes in stage 1 and 2. However, repeated traumatic injuries and progressive great accumulation have a potential to induce a self-perpetuating process. I will skip in the interest of time. Now, the spread may occur between neuronal synapses, may also involve astrocytes, microglia, and CSF pathways. Now, to conclude, the chronic traumatic encephalopathy is a distinctive neurodegenerative disease, currently can only be diagnosed with certainty in post-mortem neuropathological examination. Given the importance of sports participation and physical exercise, it is critical to identify the genetic risk factors as well as the contribution of exposure variables like stress, alcohol, and substance abuse, and other factors to the development of CTE. The acute consequences of minimal traumatic brain injury are known to produce axonal injury, microvascular disruption, breach of blood-brain barrier, neuroinflammation, deposition of small amounts of p-tau protein. Further research is needed to identify the pathogenetic mechanisms responsible for developing a long-term, often progressive degeneration after acute repetitive traumatic brain injury. Clinical and pathological diagnostic criteria have been proposed, but they remain to be validated, and additional prospective, longitudinal, epidemiological, and animal studies will be essential to establish the incidence and prevalence of CTE, to identify underlying pathogenic mechanisms that will help target future preventive and therapeutic strategies. Thank you.
Yes.
It was like a movie trailer because I was just given 10 minutes to, kind of. Yes, please.
Yes. Even then you covered well.
I tried to cut it.
Thank you very
much. Yeah, please.
Thank you very much. I'm Partho Rai, Kolkata neurologist. Muhammad Ali famously also had CTE.
Yes, clear.
Yeah. But you are describing shear forces from the top of the brain. So those were footballers. We also had an NFL player. I'm not sure whether the direction of the trauma chronically is endured by them. Boxers basically have trauma to the sides and to the front. So from your study, does the distribution of the pathology suggest the likely sources of shear forces the brain is subjected to in the different professional players, and how we can advise them?
See, and also the symptoms are different then, depending on
you didn't have Parkinsonism in your symptom slide. You had more of a dementia type presentation in the initial slides, whereas Muhammad Ali had a predominantly Parkinsonian presentation of CTE.
Right. See, this I have presented, which is theoretical, but there are a lot other symptoms which I have read. Actually, I've only read about chronic traumatic encephalopathy. We don't do medical autopsies in our center, so this is more of a theoretical, and it is all depending on which side you are getting trauma, and it is not important whether trauma is heavy or if trauma is light. Even with a lighter trauma, you can have good amount of concussion to develop all these kind of slow developing these issues in the basically around vessels and in the deep cortical sulci.
Because concussion in sports is a very hot topic at the moment, and counseling of players who are regularly involved in martial arts and in footballers as well is being advised, and they're taken off the field if they have a mild concussion injury. So maybe that's where the pathology and diffusion tensor imaging and immediate scans, certainly not a CT scan, needs to be correlated with the very beautiful pathology and the stages to prevent further
further, because right now the only way to diagnose them is post-mortem.
Yes, minor TBI, which is often, not within the domain of the neurosurgeons, is a huge public health,
Yes.
including in schools.
Yeah, and especially after they made this movie, it's become a big issue, a big this thing. People are getting aware, and there are a lot of sports people who don't want their children to go in the same sport.
Absolutely, yeah. And the choice of careers in professional sports is important. So maybe that's where our neurosurgical colleagues need to be intervening. Thank you, madam, for a very illuminating lecture. Thank you.
Thank you.
Thank
we
you.
we should stop. Thank you to all for this great session. We learn many things. Thank you.
First of all, I would like any conflict of interest.
No, stop.
But